Good morning, everybody.
Good morning. I
want to let you know where I'm from, it's afternoon. All right, I'm still not used to this. And I'm only here for a day, and then I leave tonight, and then it'll be my time again. But anyway, I want to thank you all for coming out here today. Sometimes you hear me say you all, sometimes y'all, sometimes just you. You'll hear about it. It's what you've done to me. So, first of all, again, thank you for attending our program today. This is our first program in the state of Alabama, and I do thank you for coming out. Last year, we did 30 programs in the state of Florida, and we broke out of the state of Florida for the first time. We did a program in Atlanta, Georgia. We had 175 people attend that first program. They loved it. They want us back. We felt that if they want us back, let's bring our show elsewhere, and that's why, again, we came here to Alabama. Also because there's a lady sitting in the back for years. She's been asking me to do a program here. Her name is Bryn Lee, and she's all the way back there. Thank Bryn Lee for this. So about MS Views and News, we incorporated in 2008, and why do we incorporate and do this? Well, for one reason, I too have multiple sclerosis. And we found that when I was diagnosed, we couldn't find the proper information out there. And a lot of you know what I'm talking about. You had no idea where to get the information that you know about MS now, maybe because you attend pharmaceutical programs or other organization programs. Well, we found that there is a great need in the state of Florida to do these types of education programs. And so we do them not just with a neurologist, but a lot of times we'll have a urologist or a psychologist to talk about cognition problems or the impact of MS on the family. Or we'll have a physical therapist or an occupational therapist or a neuro-ophthalmologist or something else to do with MS that we know you need to know about and you want your families to know about as well. So that's the reason why we got into creating MS Views and News, to provide it by the internet and to provide live educational programs. So since 2010, when we did our very first program, we've now done over 90 programs. So this year, this is our 15th program of the year. And last year, where we did 31 in total, we hope to be reaching closer to 40 for this year. Now, enough about me, enough about the organization. I want to give thanks to Teva Neuroscience and Genzyme, a Sanofi company. Teva, for those that don't know, make Copaxone. And Genzyme, a Sanofi company, makes the Aubagio. And without their grants to do these programs, we cannot do them. Their grants enable us to be able to do what we do. And it's not just them. We get grants from other pharmaceutical companies as well to do programs, other programs, again, whether it be in Florida or coming out of the state. And so I want to thank them, and I hope you all thank them as well. In addition to Teva and Genzyme, for today's program, we have other sponsors. We want to thank Accorda, who makes Ampera. We want to thank Biogen IDEC. They have Adherence, Tecfidera, and Tysabri. And we want to thank Questcor, as Questcor makes and provides for you Acthar Gel. And you'll hear about all these different pharmaceutical drugs from Dr. LaGanke as he begins speaking. Also, I want to thank our volunteers and the support group leaders of Alabama who have helped us to get the word out about this program. And so I want to thank them. Thank you. By the way, I don't know if I told you my name, did I? How did I forget that? So for those that don't know, my name is Stuart Schlossman. And a lot of you already know me from, whether it be the internet, Facebook, doing programs, Twitter, LinkedIn, many different places. Dr. Oz just recently gave me a nomination, not even nominate. He voted me one of 10 in the country for social media on multiple sclerosis. And so that's why we get out there and we do these programs. Again, because I have MS, because 8 out of 10 people from our board of directors have multiple sclerosis, and we know the types of programs that we feel that you need. And so we hope that when we come back to Alabama again, that you all will come and you will invite others to be here as well. Before we begin with the speakers for today, the agenda for today, Dr. LaGanke will speak for 50 minutes. Dr. Kitchens will speak for about 40 minutes, and then we'll do a Q&A. Again, remember, I need to run around the room with the microphone. And before I ask Dr. LaGanke to come up, we always ask the support group leaders that help us out to come up and speak for a few moments about their group. So I want to start with Randy Bennett. Where's Randy? There you go. Come on down, Randy. The price is not right.
Thank you. Appreciate it. For those of you I didn't get to greet, my name's Randy Bennett. I want to tell the world about MS. I'm one of the support group co-leaders in Dr. LaGanke's office. I have 3 people I would like to recognize if they would stand. John Radvillis, assistant co-leader in the Joanne P. LaGanke support group. We have Diane Sawson back in the corner, who's helped make this possible. And again, Bren Lee, with her help. She was able to get me involved to help get this kicked off in Alabama. And on behalf of Dr. LaGanke, Dr. Kitchens, and all of us with MS that want to get the word out, our support group is unique. We have been together since 2006. I have just recently been co-leader for just approximately a year, so it's a new adventure for me. I've taken my passion from my prior employment and put it in the support group. John, he's a terrific asset. He's done multiple things. He's a walking book, a big asset. He picks up the slack so that I was able to help do this and create this for you guys. And with Stuart's help and the volunteers' help, we hope you get something out of it, you learn something, and I want to thank you for showing. Appreciate it.
Thank you. Thank you. All right, next up, I'm asking Susan Davis. Where is Susan? Susan, wow, you parked all the way over there? That's a long walk. You got to run a little bit. After Susan, we're going to ask Diane if she wants to speak. So you may want to start making your way forward since you come in from the other corner.
I'm Susan Alabama. Susan Davis from Tuscaloosa, and I'm so happy to meet Stu. I've been following him for years, and I know that this is being videoed. Anyway, I'm from Tuscaloosa, Alabama, as I said, and we call our group the West Alabama because everybody knows I didn't want people from outlying areas to think you had to be from Tuscaloosa. When I was first diagnosed, my neurologist said, at that time, don't go to one of those support group meetings, they'll depress you. And I thought, okay. And so I didn't go for years and years. And when I moved to Tuscaloosa, I started going to one. And we're not a depressing group. You know, we like to, you have to laugh at MS. I tell people you've got to have a sense of humor with this disease because some of the crazy symptoms it throws at you. And so we're a pretty diverse group of people, men, women. We have quite a few men, quite a few black men even in our group, which is sort of the rarity. And I tell people, you know, you have to be ready to attend a support group, but when MS is such a complicated disease that when you get in a group of people like that and you say, I've got my leg's going numb or you have a symptom, somebody in that group will have had that symptom. They say, hey, yeah, I had that, and you know what I did for it? So that's why I think support groups are important. But like I said, you have to be ready to attend one, and we try to be upbeat, not depressing. So,
thank you. Diane. Here I asked her to come up front, and where's she hiding on the other side of the room? After Diane, we have a special support group leader that came in from out of state just to talk to you. And then we could get started.
Hi, everybody. Good morning. My name is Diane Sowson. I've been asked to come up here and talk about my self-help support group, and I'd also like to speak about my newsletter that I've been doing for the last few years because I'd like to get the word out a little bit more to other states, and as well as Alabama and Mississippi and Florida and Mississippi. Anyway, I've been a self-help group leader for about, I guess, over 10 years. And because of the self-help support group, I just found that everyone wants more education. So I decided to go ahead and do a small little newsletter. Well, that little newsletter has grown, and it's now like a 4-state newsletter, and I'm so proud of it. My partner is not here. Her name is Adrienne Connors. My self-help group support partner is over there in the corner. Deb, if you would stand up or say hey. Anyway, if anyone would like to know more about our newsletter, It is, the address for it is MS News for Us. It's just a very personal little letter. It goes out to everyone who has MS, their care partners in the states of Alabama, Mississippi, parts of Florida, and parts of Georgia. And it's just to educate, to let people know what's going on, and so we can all get together and learn together. Thank
Great.
you very much.
Thank you. You know, she reminded me, when she's talking about the newsletter, I didn't speak anything about ours either, but we have a newsletter called Stu's Views and MS News. Can you imagine that name? You know, I started that even before we began the organization, MS Views and News, and I need to remind you all as well, MS Views and News is a standalone organization. We are not with the National MS Society or the MS Foundation or any other organization. We are the grassroots up-and-coming organization. Vicki, come on down. I don't know. She's bigger than me, so I got to stay away from her.
I'm bigger than most people, thank you. My mother lied to me.
90 seconds.
Good morning. My name is Vicki Pomeroy, and I am a group leader outside of Atlanta, Georgia. Our group has been together for over 25 years, continuously. Thank you. We're the only ones in the country that have done that, by the way. Like Susan was talking about, getting the mindset to use a support group, to go to a support group and get the best value of it, we have to leave all our troubles behind. On the front door of my meeting room, I have a smiley face with a big sign that says, "Welcome to our group. This is not a pity party." We all have the same disease, the same problems. Let's get together. Because it's until you talk to other people and understand that everyone in this room, y'all know where I'm coming from. I don't have to hide anything. I don't have to put on any airs. And that is the purpose of a support group, to have someone that you can let your hair down with and get your questions answered. Knowledge is power. I also do a newsletter. If you've seen, there were a few issues out there on the registration table, but luckily they disappeared. My newsletter goes to 6 different continents and 83 different countries now. And this is what I've developed since 2000. Thank you. Yes, ma'am.
Is it on the internet where we can access it?
I send them out via internet, and I also use old-fashioned snail mail. But if you can give me your address, either snail mail or email, I'd be more than honored to put you on my subscriber list. Okay? And anyone else that's interested. I'm sorry? My newsletter is called The Explorer, because we explore everything. I've got recipes, I've got jokes, I've got stories of fellow MSers, what's the latest research. This is all what you'll get. And it's fun, and that's the main thing, because we've got to be happy. But I thank you all for inviting me, and I hope you enjoy the rest of the seminar. Have a great day.
Thank you. Thank you. All right, so now you know why we like to educate. We like to educate and make sure that you have the news from support group leaders as well, and that's not something that we don't get involved with support groups, but we do want to make sure that everybody is educated as best they can on every facet of multiple sclerosis. Without further ado, I want to ask Dr. LaGanke to come on down, because for him the price is right. Thank you,
very
sir.
much. Thank you. You need room? I think I'm good. Thank you. Well, thank you, Stu. And thank you all for coming out on finally some good weather. I know it's we have a rare day here lately, and it being so well, I appreciate your efforts to come out. And my goal for you is that you go away with something that you didn't know today, that you learn something from this program. And if you don't learn from something that I say or Dr. Kitchens talks upon, I hope you ask a question that's burning so that we can get you some information. I appreciate Stuart. I mean, you know, he put this together. He put this whole organization together without, you know, he had to go out and get funding for it. And this takes a lot of work to put this Stu's Views, MS Views and News together. And it comes out every single month with the latest credible information regarding MS. I mean, from not just medications, it's physical therapy, it's natural things. He spends a ton of time to educate the world about MS, and I really appreciate you doing that and then putting this program on today and asking me to come to speak. So let's give him a little bit of applause, please. Okay, great. Okay, well, I think it's much easier this way. So I'm going to kind of give an update on things, state of affairs today, and I think we want to be broad in our approach, and we want to do something. A lot of times neurology's been passive, or it's been passive in the past, and we have so many more options and weapons and knowledge now that we really shouldn't stand by and use the old standard. So I'm going to put in some of my philosophy in addition to the information that I present here, and you can take with it a grain of salt with it for whatever it's worth, but I feel passionate about it. Now, I do go around the world speaking and do research with medications, the latest medications, things in the pipeline that I'll talk about coming up. So these are the various organizations that allow that to happen. Here's the agenda, and it's a little bit different than the title, but I think it's important to get the whole message, get an understanding of why we choose certain therapies, why it's important to adhere to therapy, et cetera. So first we're going to talk about the impact of MS. Why are we here in the first place? Then a little bit on immunology. So that can be an overwhelming topic, but I'm going to try to just give some terms that make it a little more understandable. And then talk about relapses and symptoms, how we've evolved in diagnosing MS today. It's very different today than it was a couple decades ago. Then predictors of long-term disability, the goals of our treatments, what's in the pipeline, how to manage a relapse, how to briefly manage symptoms, because I could be here for 4 to 6 hours just talking about how to manage certain symptoms, and then general considerations that you can take home with you. So without further ado, MS is a torrent in the central nervous system. It wreaks havoc in your brain and spinal cord optic nerves. So this wreaked havoc in Cullman in April 27, 2011. This sort of thing goes on in the brain and spinal cord of untreated MS patients often. MS is fatal. This is a fatal condition untreated. 7 to 10 years on average loss of life untreated. We have to understand this. We've been blessed in the last couple decades to have medications that have made this not happen. But that's the situation we're dealing with. So this is a very serious condition. This is the #1 disabling neurological disorder of adults 20 to 50. So those are the terms. That's why you're here. That's why I'm here. This is what happens untreated. That's what happened in our town, unprotected. Well, you can imagine a girl has dreams in America and has visions of things to do and to move forward. And then a disease hits you. And a disease hits you and changes everything, not only for yourself, but for your family. Now, this is a family condition. This isn't an individual issue. Nobody's to blame. It's teamwork taking care of whatever faces us. So this young lady had MS hit her hard. There is a fine-looking young man over here, I think, right there. I kind of think he looks pretty good. But so we had to, as a family, change our summers. We had to get a place that was in cooler weather, because growing up in Connecticut, there's no air conditioning. Summers do get to 90 to 100, and she would wilt in the heat. So we had to change summers, so my brother and I would have mom duty, give up baseball for the summer, go take care of her while my dad continued to work. So we had to go up to Maine to care for her so she could get out of the heat. And then you can see the progression now with the cane. This is what happens untreated with MS. It's her mom with her, and her mom outlived her, which is always an awful thing, to outlive your child. Here she is at graduation in college at Chapel Hill. We can see just the natural progression. And then you die from MS. So she died at the age of 62, which is the average age of death for someone untreated with MS. And you can see here the lesions of MS, the brown areas that are scattered throughout the white matter and around the ventricles. This is a ventricle of the brain. So this is a very serious condition, untreated. We're, again, blessed to have medications and lots of choices that allow us to make a major impact in stopping this disease from getting to this point. Sorry. So that brief immunology, just a couple slides, bear with me. So T cells are the major player in MS. They're the cells that migrate across the blood-brain barrier. They're activated in the bloodstream and then home in on the central nervous system, something on the myelin, and attack the myelin for some reason. And there's a change in the type of cells that we have. As you can see here, I'm not going to go over the particulars, but T cells make their way across. And our immune system is supposed to recognize ourself. So it's supposed to recognize that myelin is not to be attacked. But there's something on the myelin surface that looks like something else that's foreign to us. And ordinarily that's not a problem. But with MS, part of the genetic defect is that we don't recognize that antigen in the context of ourself. And we end up attacking that part of myelin thinking that it's something foreign. Very complicated immunology is, and just a naive T cell, when it's stimulated in a different environment with different chemicals, will turn into a different kind of T cell. Some of these T cells are bad in MS, and some of these T cells are good. But they all start out with a naive THO cell, and then it just depends on a lot of other factors as to whether it's going to attack or not. B cells are also important in the immune system. And they can present things to the T cell to stimulate them. They can create antibodies that cause a problem. And I think some people with MS are more B cell predominant, some are more T cell predominant. So some of our therapies that may not work, it may require us to have this understanding and switch gears to one that concentrates on the other part of the immune system. These are CD52, CD25, CD20 are surface markers on immune cells. And I just put those out there because I'm going to talk about some of the medications we have or in the pipeline that work on those particular surface molecules. So I talked to you a little bit about the family cost, and you well know the family cost of this disease. It changes everything. Doesn't necessarily mean for the worse, but it changes things. And then there's economic cost. So there are a lot of numbers here with lots of high numbers of dollars as far as the financial impact that this condition has on our society. And that's, to me, less important than the family impact, but it's important for getting research dollars and to get support nationally to try to rid ourselves of this disease. The largest piece of the pie, as far as economic cost, is early retirement. So early retirement, loss of the ability to work, that's the largest cost to society that we have today. Relapses also cost a lot of money. So a recent study, Journal of Neurological Sciences, that looked at just insurance claims and how much does a relapse cost? Well, a low or a moderate relapse, one that doesn't take you down so severely, has an average cost, direct and indirect, $9,700, and that's just for insurance claims. There are other indirect costs that are sizable. A severe relapse, about $27,000. And someone came up to me before the program who had had a recent severe relapse in a facility for 11, 12 days. That's very pricey, and that would fit into this cost of getting over or trying to take care of a relapse. So what is a relapse? A relapse is a new neurological deficit lasting at least 24 hours or a marked worsening of an old deficit that doesn't have a good explanation. And it's different than a pseudo-relapse. So a pseudo-relapse is, let's say you had a paralysis on the right side in the past, improved, got over that relapse. A couple years later, working out in the hot sun, that right side gets weak, you start dragging your foot, come inside and cool down, and it goes away. So that's not a relapse. That's not any more damage being done. It's just that the old area of damage doesn't function very well in stress. And that stress can be a good stress or a bad stress. It can be a urinary tract infection, recent immunization, winning the lottery, getting fired. Any sort of stress you can think of can impact that weak link. So those scarred areas in the brain are weak links. And they're going to feel the effects of stress. And you're going to have symptoms. So symptoms coming out, if they're old symptoms, typically they're not a new relapse. They're not new areas of damage. It's just stress on an old scarred area. Now, why are relapses important other than the obvious inconvenience or problem that they cause immediately? Well, they have predictive power. Those relapses that occur early predict long-term disability, even if you get over those relapses well. So the number of relapses that occur early predict how disabled you will be later on in the absence of effective treatment. So now we have treatments. That's why we have we preach treatments. And recovery from a relapse has predictive value, which I will tell you about shortly. How about symptoms? Well, the symptoms all depend on where the lesions occur in the brain and the spinal cord. So if it happens in the optic nerve, you're going to have painful visual loss. If it occurs in the motor center, you're going to have some kind of weakness somewhere. It can affect sensory system. You can have vertigo, swallowing difficulties, balance problems. You can have numbness or a tightness around your abdomen or around your thorax, the MS hug, so-called. But the biggest ones that plague people, I think, by and large, are the hidden ones. So the silent ones, mood changes. Oh, you don't be depressed. Johnny across the street's in a wheelchair and you're not that bad. You know, those are comments of someone who has a mood problem from MS, directly related to the lesions of MS. They interfere with a chemical channeling, which leads to a chemical imbalance. It's not that one feels sorry for themselves and lo and behold, I have depression. The lesions actually cause the mood disorder. Fatigue, #1 disabling symptom of MS. In other words, the #1 reason people get on disability in the United States from MS is fatigue. It's not being in a wheelchair, not falling down, not being blind in an eye. Fatigue. Pain. Bowel, bladder, sexual dysfunctions, and then cognitive problems. All of these things are not visible on the outside, but are going on like that torrent inside the brain. And thank you, caregivers, for coming today to learn about this, because these are invisible. And how would you know? How would you know that they're occurring? A lot of times you may be at work and can't come to the doctor's visit, so you can't learn about it that way. And we all make judgments. We have to make judgments to get along in the world. I can't interview everybody and find out what they're like. We look at someone, they're walking a little more slowly, they have bags under their eyes. I would assess they're tired. The fatigue of MS is not like that. It's like the stuffing's been taken out on the inside. So a spouse will say, well, I'd love to go out to eat, but I'm tired. The other spouse may not get it. You don't look tired. I don't understand that. And those little light bulbs go out, those little thoughts. She's still mad at me for this or that, right? So it takes understanding that these are real legitimate problems that a person, they're not trying to get out of anything, they're not feeling sorry for themselves. These are symptoms that they have to contend with each and every day, and be a partner, be a teammate. If you're down, they'd pick you up. They're down, you pick them up. So this is a very common slide that's in most MS talks. It just talks about clinical attacks that occur, which are the histogram bars. Those are attacks. And the orange graph is the T2 lesion load, or the amount of MRI lesions that occur over time. And as we have more attacks over time, we gain disability. Well, over here are terms RIS, radiographically isolated syndrome, clinically isolated syndrome, or CIS, relapsing remitting MS, secondary progressive MS. This is really a time course of what happens in someone with MS. It's not that they're necessarily anything different. Someone started out with lesions before they had symptoms, and then they had one event, which is CIS, and then different attacks. And then there may be some slow progression, which is secondary progression. It's not a different type of MS. It's all the same MS on a continuum of time. Traditionally, and when I did my training with Dr. Whitaker at UAB, we were bound by the Poser criteria, had to have 2 clinical attacks in order to be diagnosed with MS. A person would come in with a devastating attack, let's say a young lady, typical profile, no other reason for it, MRI has many lesions. Well, the good news is I can't give you a diagnosis of MS because MS is multiple sclerosis and you haven't had multiple attacks. That was a phraseology we used in the early 90s because we didn't know any better and we thought we were bound by these criteria. 9 out of every 10 lesions that occur in the brain are silent. So that's a lot of damage that accumulates over time before you have a clinical relapse. So that didn't settle all that well with us, that we had to wait for somebody to come back and have 9 more lesions before we could diagnose them. So the McDonald criteria came about in 2001. And this allowed us to diagnose people with 1 attack and certain MRI features. That was a huge revolution in earlier treatment of MS. So instead of having to diagnose someone over here with a second attack, we now could diagnose someone here, first attack, less MRI lesions represented by those arrows. And the clinical disability long-term we would expect would be better because we've accumulated less damage. Well, 2005 revision of the McDonald criteria allowed us to diagnose even earlier. Didn't have such criteria as we had to wait 3 months for another attack or another lesion. We could do it maybe in 30 days now. And then 2010, this is our latest criteria on how to diagnose MS. And now we just need 1 attack and 2 lesions of a certain kind, and we can diagnose MS. Just 2 spots in the brain, and we can implement treatment. As long, of course, as we rule out the mimics. Because there are other conditions that mimic MS can put white matter spots in the brain and can cause neurological deficits. So not everything that's a white matter lesion is an MS lesion. So the latest criteria, yay, minimizes the need for spinal fluid. I know you all love that spinal tap that you had, but spinal fluid's really been taken out of the criteria as something that we need to do to diagnose MS. It's not in the criteria as something that's valuable most of the time. So we're doing a lot less spinal taps, which is less invasive for you all. Here's a partial list of the things we have to think about that mimic MS. Some of them are realistic and some of them are, very exotic conditions in certain areas, in certain family histories. But it's a sizable number, and it really talks about diseases that are associated with dissemination in space, meaning that you have different lesions in different areas of the central nervous system, or associated with dissemination in time, where more lesions occur over time, or some that have both. And you have to memorize that before you can leave. I don't know if anyone told you that, but I'm sorry, I'll flash it one more time. And then we need to be careful in our diagnosis, and we need to make sure that it's a correct diagnosis. There are some flags for us that say, well, maybe this isn't MS. Having these symptoms does not exclude a person from having MS and that they're causing their MS, but these are just things that make us put up the flag and say, did we really make sure that there isn't something else going on? Now, radiographically isolated syndrome. So this is when Johnny hits his head, when he falls off the bed, goes to the emergency room, has an MRI scan because he's still a little bit groggy, and there are a lot of lesions in the brain. Maybe not Johnny, maybe John. But it was first described 2009 by Dr. Kudo, and the MRI looks for all the world like it's MS, but there just never has been a neurological event. Haven't had paralysis, numbness, bowel bladder difficulties, balance issues. And so we're looking for predictors when we see an MRI like this, because it doesn't automatically mean someone's going to have MS. Can we get something out of this situation to say, hey, this is MS, and let's treat it before we ever have a symptom? So what's the rush? Well, the erudite pushback would be, we don't really need to treat it because the person's neurologically normal. Okay, that's kind of the very lofty way to look at that. We don't need to commit to a medication because we don't have any neurological deficits. Well, do we want to wait for neurological deficits? Wouldn't it be wonderful if we treated MS and someone never had a neurological problem their whole life? Wouldn't that be the goal? That's the goal. We need to kind of step back and say, well, we don't need to have rules. We need to work sooner in this disease stage to stop it. It gives a person a sense of normalcy. The cost associated with it's reduced. And we know that there's a window of opportunity. If we treat effectively early, we have very good gains down the road. So there may be a window of opportunity when we break through and have enough disease go on, we're not so effective in our treatments anymore. So all of those reasons are reasons why we should look for, hey, can we diagnose this before there's a problem or at the very earliest problem that comes up? So clinically isolated syndrome, a couple points out of this case that came into my clinic a few years ago. A 45-year-old lady had left optic neuritis, visual loss in the left eye, and pain with eye movement. Saw the ophthalmologist who appropriately thought it was optic neuritis. He sent her for an open MRI scan and referred to our clinic, came into our clinic within 2 weeks, and the MRI report was normal. And I looked at the MRI myself, which I feel a good clinician ought to do because we're making decisions based on that scan. And there was one clear lesion in the white matter, and there was another one that was iffy because there are some normal abnormalities that we can have on a scan, and it was kind of bordering on that. So really one definite lesion in optic neuritis. Very important to know if there are two because that allows us to substantiate a diagnosis and start treatment if it's there. And if it's not, then it's not, and that's very important too. So we set her up for an MRI of her cervical spine, which is normal, looking for any other lesions. And I asked them to throw in a freebie sequence of the brain because this scan is 10 times the strength of an open scan. 10 lesions on that scan. And that was within a day or two from the other scan, and there weren't any active lesions. So they were there before, but you couldn't see them on an open MRI scan, which is a very, very weak scan, a weak magnet. So one point is we need to look with our best magnets possible. And we need to look at them ourselves. And we need to be diligent in this. And so she was diagnosed, saw her back a month ago, hasn't had any other events, still has her 10 lesions, cruising along, working, and feeling well. And we, of course, we excluded every other condition. We did the usual test for mimics, and that's always important to do. So a person presents with an attack. Natural history studies say that people who have an attack and have lesions are going to go on to have MS at a very high rate down the road. With our latest criteria, CIS is becoming less and less of an issue because before we had the latest McDonald criteria, a person could have several lesions, only one attack, and they were still clinically isolated syndrome, not definitive MS. But with the latest criteria, CIS has become less of an important issue because most of those people are diagnosed with MS at that time. And just a couple of pieces of information from natural history. A person who presented with CIS in the past and had at least an abnormal MRI, 88% went on to have a second clinical attack diagnostic of MS. Only 19% went on if they had no MRI lesions at that time. So if someone comes in with optic neuritis to our clinic and they don't have any lesions whatsoever, they have a little less than 20% chance of going on to develop MS over time. Whereas if there's just one lesion and there's no other reason for it, a person has an 88% chance of going on to develop MS. The number of lesions doesn't matter. It could be one lesion and 80+% are going to develop clinically definite MS. But the number of lesions that are present predicts how disabled a person's going to be over time. So that baseline MRI, if there are 10 lesions, a person's predicted 70% of patients would go on to have visible MS. Other areas that are affected like a limp or some other noticeable problem. EDSS of 3 is noticeable MS, EDSS of 6 is using a cane. So the number of lesions at baseline in that study predicted how disabled a person was going to be. Again, before the advent of treatments, just to give you a taste of the natural history of this disease. So now, a 29-year-old gal came to clinic a couple weeks earlier, had numbness in the right side. She was pregnant. had an MRI scan done, which I'll show you in a minute. The symptoms had abated by the time she came to clinic. We allowed her to finish pregnancy well, and she did, and had a healthy young boy. But as she only had one lesion on her brain, we instituted the quarterly MRI monitoring looking for change, which is what a lot of MS specialists will do at a first event and only one lesion. So she had an MRI after delivery, another one, and then 8 months after delivery, right-sided numbness, imbalance or ataxia, slurred speech, and progressive weakness. And this is a picture of the original MRI scan. So anyway, she had a lesion in the left side of the brain, which was responsible for her symptoms. We'll see if we do a little bit better with the next one. Okay, there we go. So here's the original area of abnormality, the white area right here, and over here, it's the white area right here. And on the next slide, this is then when she had her symptoms. So now you see a little bit more disease there. So now she has spots here, 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 and here. And as we go on, she has a large lesion she didn't have up here, another lesion here. And then after the administration of dye, several of these picked up the dye, which meant they were actively eating away at the brain or inflamed in the brain. So that's a typical course of relapsing remitting. Have an attack, get better, 8 months later, another attack, a lot more lesions. It can happen quickly. Why treat early? Well, we know now from our natural history of treatment that if we wait 6 to 8 years to treat, we do pretty good at cutting down attack rate. But if we treat earlier, like I said, that window of opportunity, we do far, far, far better. And I'll show you some of those examples with some of the treatments that we have available now. And if we don't treat at all, the natural history of MS, 90% of people go on to develop secondary progressive MS. If they're diagnosed with relapsing remitting, no treatment, 25 years later, in one study, 90% of people go on to secondary progressive MS. Now, this is a long-winded history, but I think it gives us a few more important points. So here is a 20-year-old African-American female, 2000, had headaches, fatigue, right facial and skull numbness, lost her job because of fatigue at 20. In May, diagnosed with MS, referred to our clinic, and she was 4 months pregnant, and she had a lot of problems. Brainstem attack, double vision, vertigo, nausea, vomiting, couldn't remember things, very fatigued, weak in her legs, very stiff and spastic, she had numbness in her hands, bladder incontinence, a real firestorm of an attack. Soon after delivery, her exam was normal. She started on treatment. 9 months later, her exam was completely normal except for some hyperreflexes. And to this day now, that was 2000, to this day, she's still the same. Okay? And that's unanticipated. But this was her scan, and you can see the white matter lesions here. And you can see the white matter lesions here. And you may or may not see this, but there's a cord lesion here, and there's a cord lesion here. So up here, that white area right next to the light, and then there's another one here. So she had 2 cord lesions as well. So I present that case because that highlights a few things. We have predictors of disability. They're not perfect. So someone who has the onset of MS over 40 has a lot of different symptoms with a relapse. So it's not just numbness or just visual problems, but if they have vision problems plus they're weak, plus they're numb, much worse prognosis. If in between the initial attacks, the second one occurs within 2 years, that's a worse prognosis. Higher number of lesions at baseline, I already mentioned, that's a worse prognosis. The attack rate, the number of attacks in the first 2 years, if it's more than 2, that's a bad prognosis. And if there's an incomplete recovery from the relapse, or if you're a male, worse prognosis with MS. So these are not set in stone, but these are just statistics. She had multiple symptoms at onset. She had her second relapse within a year of the first one. She had a high number of lesions, including spinal cord lesions, high attack rate. But she's doing great because we went on therapy. We didn't just follow these and say you're going to do horribly. We set a high bar of success of treatment. She stuck with it, and she's doing well. So natural history tells us some things too. That EDSS is our disability scale. A disability scale of 4. When 1 hits that, there's a lot of information lately that you don't stay at that level very long. You're marching to a cane in very short order. It may have taken many years to get to 4, but once you're at 4, it's a slippery slope down to 6. Earlier age of onset, being male, being African American, are risk factors for earlier age of disability. So those are from our natural history studies. Now, just some brief words on secondary progressive MS and primary progressive MS. Secondary progressive MS, really a wearing out, we think, of the old lesions that have occurred. It's kind of like a frayed cord. Over time, it's going to fray more, and then not work very well. And that's what we kind of think happens with secondary progressive. So it's not a different disease. A person can still have lesions. A person can still have relapses with secondary progressive MS. So let's take the scenario of someone being in a wheelchair. They've been ravaged already by this condition. They're diagnosed with secondary progressive MS. Shouldn't we still save their arms and their brain? Isn't it worthwhile? Well, there's an initiative out there to say that secondary progressive is not worth treating. Okay, that's something that was brought out last year and put forth as a Choosing Wisely program of trying to lower our healthcare costs. Each specialty has taken 5 subjects or topics to look at to say, are we really cost effective or not? And last year, the first year it was chosen, secondary progressive MS was on the chopping block. And the conclusion was not worth treating. Not cost effective, because the way they looked at it was all wrong. No, we're not going to undo what's already happened. But we can stop new things from happening that are going to unravel and cause a problem 10 years down the road. And no, we don't have absolute proof, but you can come to my waiting room and you can come to a lot of neurologists' waiting room and you can see the lowered number of wheelchairs that are in the waiting room because we've implemented treatment, which has had long-term effects. Primary progressive MS, 5 to 10% of people with MS have primary progressive. We're really frustrated with this type of MS. We do not have effective treatments for primary progressive MS. There are some unique features. The disability with primary progressive is guided by the first few years of disability and how a person progresses. Usually starts with walking problems, so it's not like my foot became weak and then it went up my leg and then my whole leg's weak by a week's time. It's just maybe stumbling for a month and then it's just a little bit weaker. It's not like a relapse that you pretty well can tell has come on. It's more of a very subtle worsening of neurological function. Usually there are less lesions in the brain, spinal cord, less of them are active, more often in the spinal cord. Average age of diagnosis is 10 years later, so an older population gets primary progressive MS. And here we have a ratio with the sexes that reaches parity, or male-female ratios equal. With relapsing remitting, it's 2 women to every male. So it's 2 to 1. So here it's 1 to 1 with primary progressive MS. Okay, so now we get to therapy. All right, and I coined this term back around 2000. I said, what are we looking for out of our treatment? I just asked myself, probably stumbling out of bed or in the shower or something. So what are we trying to achieve with the treatment? Well, I played baseball in college, so this kind of analogy came well to me. I said, we're looking for 4 things. We're looking for a well-tolerated, safe medication. Because if we fix MS for the next 50 years of your life and you feel lousy 1 or 2 days a week, that's not a win. So we need it to be well tolerated and as safe as possible. No relapses. No worsening of your exam. No new MRI lesions. I would challenge you that if you achieve that home run, you're on a very effective treatment and probably don't want to leave that treatment. So this is what I challenge my patients with. This is what we're looking for. Because I think when people know why they're doing something, they have more of a tendency to be compliant and adhering with it. Well, why did I pick those particular parts? Well, number one, long-term disability is predicted by early relapse rate. So the number of attacks early predicts long-term disability. We know that from Dr. Weinschenker way back in the 80s. That someone, so here is percent patients who use a cane, 100% down to 0%, and then we go time onset of MS. If there's a low attack rate, 0 to 1 in the first 2 years, it's a yellow bar. If it's 2 to 4, it's an orange bar. And if there are 5 relapses in the first 2 years, it's a green bar. So the percentage of people not using a cane, not very high if you had a lot of attacks. So the attack rate predicted how a person was going to do with walking. And then how about a relapse itself? Each relapse can leave some baggage. Okay, I'll have some patients every year that come to the clinic and say, well, when am I going to get in remission? I'm not normal. Unfortunately, remission doesn't mean normal. Remission means you're not having a new attack. We would love for it to be normal, but it doesn't always mean that. And each attack can leave something behind. So 42% of people have a half-point gain of disability permanently after a relapse, and 28% have a 1-point increase on our 10-point disability scale. So those relapses can get us closer to that EDSS of 4, which is a slippery slope to the cane. So we want to aggressively treat relapses, which I will talk about. So relapse rate, important. We want no relapses. That's going to predict a better outcome for you. How about MRI? MRI is a very good biomarker. In medical school, in residency, internship, we learn treat the patient, not the test. Treat the patient, not the test. If they're doing well and they have an abnormal test, don't treat the test, treat the person. Have some common sense. Well, you can take it a little bit too far. So someone has a cholesterol of 500, they're not feeling poorly, but you're not probably going to idle and let that go. Well, that would be similar with the brain. Lesions predict disability. So it's an independent predictor of long-term disability. This is a study by Prosperini that looked at what were the important factors that occurred in a person that led to worse disability. 1 new lesion, 2 new lesions, 3 new lesions, that's a hazard ratio, high number of predictive value for someone to go on and be disabled with just 1 lesion. That 1 lesion dwarfed the disability score at 1 year. It dwarfed age at starting a medicine or an active lesion at baseline, 9.6, and then 2 lesions and 3 lesions, almost linear. For every new lesion, much higher prediction of disability over time. And if you looked at people who had subclinical disease only, so these are patients who had no new neurological problems but new MRI lesions, look at that. Huge numbers to predict disability at further exams down the road. And I'm going to berate this point. New lesions at year number 1. So these are new lesions that occurred at year number 1, predicted patients who had more disability, worsening of their disability score. And this is a little hard to see, but you can see the graph, and that's the most important thing. This was a study by Filippi. Different group showed the same thing. The number of lesions early predicts how disabled a person's going to be over time. So I think there's no doubt that MRI is a great value for us in determining long-term disability and ways we might, things we might do to intervene and stop that. And one last one, people who are on treatment, the greatest predictor of disability worsening over the next 18 months was a new lesion at 6 months. Didn't have to have any symptoms with that. Most of them didn't. So just that silent lesion predicts disability. In the original study, Brex from Queen Square back 20 years ago, those who had more lesions to start with developed secondary progressive MS, accumulated lesions, worse disability, milder disability, no disability. So again, just belaboring the point. So, well tolerated. Of course, I care how you feel. It's not just that we fixed your MS and you feel lousy for the rest of your life. That, again, is not a win. Relapses predict disability. Of course, if you're worsening on the exam, the medication or treatment's not holding you, and if your MRI is changing, I hope you see that that's predictive of worse things to come. Now here's the second graph you have to memorize with color before you leave, okay? So this is the trends from our clinical trials. These are the clinical trials that we've had from the very first one, way back, glatiramer acetate, Copaxone, and the interferons, and we look at the annualized relapse rate. So about 0.6 relapses per year, 0.8, almost 0.9 relapses per year, almost a relapse per year. So you can see those. And then you see this dotted line, 2000. Well, this is when we were able to diagnose MS earlier. And look how well people have done in the clinical trials when we treat earlier. Marked decrease in the number of relapses. So when we treat earlier, better outcomes. So maybe these guys here get a bad rap, these treatments, because they were used when people had a lot of disease, had it for a while, and people still quote that these medicines only cut down relapses a certain percent. But when we use those same medications later on, they really work a lot better. So adherence compliance. So I try to talk about the home run of therapy when we start therapy, when we switch therapy, so that you value the action of taking your therapy. Anything we do or don't do is because we value it more than the action or inaction. So I would like you to value the action of taking your treatment and show you that that's going to have some very good long-term consequences for you. A person who's compliant just goes along with it. A person who's adherent is really trying to do all they can to follow a good treatment course. And you shouldn't believe that by not telling us that you're not taking your treatment is an okay thing. You won't hurt my feelings. I care about what happens to you. I really don't care about the other parts of things. So if you're not taking it for whatever reason, let me know, or you don't want, hopefully, preferably, you tell me you don't want to take it before you actually stop taking it, so that we can explore that. Are there ways to lessen the problem, or should we switch to something else? But treatment's important, vitally important. In the interest of time, I'm going to kind of go through a little bit faster. So that was a case study of someone today who might present. What do we choose? What are we going to use to treat MS these days? There's a lot that goes into that decision. So it's not just, here, take this kit home and this kit and go look at it and you tell me what you want to do. That's what we did in the 90s. Okay, we shouldn't be doing that anymore. So from an effectiveness standpoint, how well do these treatments do with relapse rate reduction? How well do they do with keeping disability progression down? How well do they do at keeping new MRI lesions from occurring? And then some of the medicines have start challenges. You have to get labs beforehand. You have to have an eye exam, maybe an EKG. Have to have observation with the first dose. Have to set up an infusion site. Have other drug-drug interactions. Maybe you have a condition that makes this medicine higher risk for you. And then once you're on a medication, have to keep up with the labs, have to have an eye exam. Oops, I got pregnant, or oops, I want to get pregnant, or that changes because the medications can be toxic. Are you compliant? Do you get tired of the injections? Are you just tired in general, fall asleep on the couch, don't take your medicine? Medication might cause difficulty with skin changes. You may have to stay up to date and have blood tests to see if your viral risk is this or that. You may have to have medications recertified, cost of infusion nurses, neutralizing antibodies that may interfere with the effectiveness. And then there are safety and tolerability issues unique to the different classes of medicine. So a lot goes into that decision about what medicine. It's not, let's try this, doesn't work out, we're going to go to that. We try to get it right the first time. Try to minimize switching from one to the other. So it all depends on your perspective. Okay, where are you coming from? Okay, and that one's a little difficult to see, but we'll move forward. I love this quote from Sir William Osler, physician back in 1892. If it weren't for the great variability of individuals, medicine might as well be a science and not an art. And as you saw, there's a lot of things that go into that artistic decision of what are we going to do. It's not just a cookbook, although we're headed that way, unfortunately. So evidence-based medicine, where everything we do has evidence for it, that's an ideal. I'd love to have definite evidence for every single thing I did. But in the meantime, until we have that, we need to use common sense. And just because there hasn't been a study that proves that breathing air on the day of a full moon is necessary for life, even though we don't have proof, breathe anyway, please, okay? But they're asking us in medicine, every single thing we do, we have to have a clinical trial that proves it. That's to your detriment, I'll just tell you that, and that's the way we are headed. Every single medication we write for, even if we have common sense, we know it works, this is a good choice, if there's not a clinical trial to prove it, we're going to have a hard time getting it to you. So we need to have a voice against that. All right, so I'm going to give you just little quick pearls about each of the medicines that we have, and little interesting points about the medicines, because not one's going to fit everybody. So interferon beta-1b, or beta-seron, prolongs life. A study showing that it normalizes life expectancy. It's the only medicine to show that. Of course, it's been around the longest, so it had the chance to show us that. Doesn't mean the other ones don't, but that's a feather in the cap. And how significant was that? Well, the number of patients needed to be treated to prevent one death was 8. 8 people on beta-seron prevent one death. How about aspirin? 67 people need to take aspirin to prevent a death from a heart attack. So this is a fatal condition. Medications are helpful. That's the point. This medication's also been used in CIS, and again, it was one of those ones that you had a 30% reduction rate of relapses, and that's still thrown out. That's not how this medication works when we use it early. So individuals have that less than 3 score 80% of the time at 8.5 years in the most recent study. It's different from the pivotal study. It has a major impact on brain lesion accumulation. Rebif, or interferon beta-1a subcutaneous, first medicine to demonstrate statistical significance in those 3 important measures: relapses, disability progression, MRI change. And now there's a new injector that makes it very, very easy to inject the medication. Glatiramer acetate, or Copaxone, just approved this last month, 3 times a week, 208 less shots per year. Yay. The only medicine that's a category B for pregnancy, which means you don't necessarily want to rush to get pregnant, but there hasn't been any harm that's really been linked with this medication. And then it has a long, long history of safety. Interferon beta-1a, 1m, Avonex, it was the medication that led to the change to CIS and us diagnosing early and treating early. In the CHAMP study, they looked at what if we treat earlier with one attack, so we can thank them for allowing us to start the ball rolling to treat you earlier. And they also have a new pen with a much smaller needle available. Fingolimod, first oral therapy approved, 3.5 years experience now in the real world, over 84,000 patients. Very good 3-year brain atrophy data as far as keeping the brain from atrophying, which happens with this condition at a higher rate than without. It's a little bit of a hassle to start, but it's a well-tolerated pill once you're on it, and it showed benefit regardless of gender, age, race, disease severity. We need to educate, and I know I'm going to just go over a couple minutes if I don't get yanked off the stage, but this is an important point. So this is the only medication that lowers your white count so that when you draw blood, it doesn't matter, okay? We learn from first day of drawing blood, when we draw blood, that white count tells us what's going on in your system. Very, very high, you have an infection or cancer. Very, very low, could be an infection, could be that you're immunosuppressed. You could have AIDS, could have been treated for cancer, and on chemotherapy. And so that's how our medical world sees drawing that blood out of your arm. This one medication blocks circulating lymphocytes. So it traps them in the lymph nodes. And that's only 2% of all your lymphocytes. So the 98% of your other lymphocytes are doing great in the tissue where they need to be. So it's an artificial value. And I presented last year at a national meeting the lack of any correlation of any kind of infection with the white blood cell count on this medication. So there's no correlation with risk of infection with a low white count or low CD4 count or anything like that. But you need to know if you go on this medication. I've had 2 patients this year. One had a headache, little scratchy throat, went to the ER, white count 1, admitted to the ICU, bone marrow biopsy, spinal tap, isolation, antibiotics. It was a normal occurrence due to this medication. Didn't need any of that. And so patients have had referrals to hematologists, et cetera, because of a low white blood count. That's a waste of your time, your money, the physician's time, money, et cetera. So you need to be educated, and we're working on getting a card that we can give to the primary cares in the ER so they know about this medication. Teriflunomide, second oral medication, also called the Baggio. This medication was used like the original studies in people that had a lot of disease, 8 years. So the numbers don't look as strong as the other orals, but that's because the populations were different. So there's a danger when we try to cross-compare numbers from one trial to another, because the populations may be very different and you're comparing apples to oranges. This is the only medication that has 2 phase 3 studies that show a significant benefit in disability. It's safer than it's stated. It got a lot of baggage from its parent compound used in rheumatoid arthritis. It's a category X, which means you can expect some fetal problems with this medication. Now, category C is we would never test a human, and you shouldn't get pregnant on C, but it's not as strong as an X. But we don't recommend anyone who is on a category C medication to get pregnant, and X is the same. So it really doesn't make a huge difference. We don't recommend getting pregnant while on therapies with an X or a C category rating. Now, we'll skip the mechanism of action. Dimethyl fumarate or Tecfidera, the latest oral therapy, about a year now, a little over a year now. Most prolific new start of any of the medications. It's a solid medication, very clean as far as side effects. The one side effect, GI issue, we're still trying to figure out how to best overcome that side effect. That's been very troublesome to a lot of people. Natalizumab, Tysabri, it's our most effective treatment. Number-wise, there is a virus, JC virus risk. 50% of the adult population has this virus in them, and if that virus happens to go to the brain and you don't have any lymphocytes in the brain, you can get an infection called PML, which can be deadly. The latest numbers, that risk is less than 1%. If you have the virus and you take the medication for 6 continuous years, the risk of that brain infection is less than 1%. So we don't want to take any risks we don't have to, but it's not a huge risk as far as number goes, just so you know if you've tried everything else and you know what MS is like. So that's a decision to be made. Mitoxantrone, this is a chemotherapy agent that was our go-to medicine a decade ago. Rarely used now because leukemia has occurred 1 in every 150 who have taken the medication some years later. So we don't use that very much. So it's clear what we should use to treat, right? Okay. So what's in the pipeline? And I promise I'm going to be 5 minutes, Stuart, if you'll indulge me for 5 more minutes. Is that okay? Sorry, Dr. Kitchens. What's in the pipeline? So what's coming? And this is just a small number of things that are in the pipeline. Rituximab, ocrelizumab, ofatumumab all work on that CD20 molecule on the surface of lymphocytes of B cells, naive and memory B cells. And it has very, very effective in keeping relapses or new lesions from occurring. And it's infrequent in the dosing. Rare potential dangerous side effects that we're still trying to sort out with these later studies. Teclizumab on that CD25 surface molecule, that CD5 molecule is upregulated when you have MS and you have disease activity. So targeting that would be more specific than taking out all of the T cells. So if we could target just the ones that are being upregulated during MS, that would be a more precise medication. This is in a phase 3 study. Once a month under the skin shot. BAF, as we call it, or BAF 312. This is the next generation of Gilenya, or the S1P agonist medications. The goal of this medication is to try to decrease the cardiac heart-lowering side effect of Gilenya. And there are several phase studies underway. There is a trial in secondary progressive MS with this medication. Plegridy is Avonex, basically, that has many Avonex molecules around a little wheel. So you get a lot more of the medication. It can be given subcutaneously and every 2 weeks. This ought to be approved this summer. So this will be the next approved medication likely for the treatment of MS. Laquinimod is an oral pill that's looking to do better in trials. It does have some results in disability, but it's now being tested at a higher dose than it's ever been tested before to see if we can get enough benefit to bring this to market. Cladribine was an oral pill that you just took once or twice a year. Unfortunately, there were some malignancies that showed up in the trials, and it was not pursued to be approved in the U.S. It is approved elsewhere, and they may be working on those issues. But anti-lingo, this is the first monoclonal antibody to repair or remyelinate damaged tissue to bring back function. So this antibody fixed the lesions in the spinal cord of animals with MS and restored function. We're now in a phase 2, so we've been blessed in our center to be one of the 10 sites to study this medication, and we're about 5 months into it. Stem cell treatment, everybody's interested in stem cell treatment. 2 trials, about 2 years or so along. We're just waiting to see what that shakes out to be. And there are many, many, many others, and some of them are in primary progressive MS, thank the good Lord, and some in secondary progressive MS. So a lot of medications. You look at the pipeline, it's many, many chemicals. You can go to nih.gov clinical trials, and you can see all the things that are in trial. Next to last subject, Alemtuzumab. This was a medication that the FDA turned down December the 30th, citing a problem with the study design as a reason for not approving this medication. The CARE MS 1 and 2 studies, I'm going to breeze through these. These were studies that we participated in. This is a once-a-year IV for 2 years, and then the hope is you'll never need another treatment for MS again. And that's what these studies looked at. So the CARE MS 1 was in patients who were treatment naive, and 2 in patients who had failed a treatment. And the results were compared against Rebif, which, remember, was the one that showed statistical significance in all the measures. And you can see here that Lemtrada is here, Rebif is here. So a significant reduction in relapses, in enhancing lesions. Time to disability in one of the 3 studies was not significantly different because the Rebif people did so well in this study, unexpectedly. But in the other study, you can see a significant difference in disability progression, and in the other study, there was still a significant reduction in relapses, and there was actually improvement in neurological function. So this is the only medication in MS trials where the patient is better at the end of the study, and it did it in all 3 studies. And same with cognition was improved, sustained disability improved in the other study, side effects fair and balanced. There are some autoimmune conditions, thyroid disorders, platelet problems, kidney issues, infusion reactions, infections that we need to be aware of with this medication. Last 2, symptom management. We have a lot of medications for the various symptoms that you have. Just because you have a symptom doesn't mean you need to take a medication. But if the symptom is impairing your quality of life, odds are we have something that we might be able to give you to help decrease that side effect or that symptom to make your day-to-day living better. These are some of the more common things that we treat. As far as relapse treatment, is it worth treating someone with a relapse? The old dogma, and still taught in medical schools, is steroids just bring you back to the place you would have gotten anyway. They really don't do anything special. That's based on an observation in an old study that wasn't designed to look at that. There are 11,000 snipped wires for every cubic millimeter of enhancement or dye that's taken up in a brain lesion on biopsy specimens. So a lot of cells in that inflammation, a lot of your neurons are being killed with a relapse. So IV steroids are the go-to. Acthar ACTH is a great go-to if you haven't fully responded to steroids. Plasmapheresis is sometimes used. The big thing is we're not taught how to treat relapses in our training. There's a relapse, this is what you do. But like I said, the closer we get to an EDSS of 4, the closer we are to a cane. We need to get you back to where you were before the relapse as best as we can. So I give general advice, whether it's IV steroids or Acthar that we're using. If you're not any better in a week, you need to let me know. If you initially got better and then started getting worse as we came down on the dose, you need to let me know. And then you need to follow up in 6 weeks, because I need to make sure that you're back to where you were to begin with. 3 months follow-up, too late, already sealed the deal, scars done, and that's what you're left with. And we saw how many people have some permanent residual from their relapse. So we need to be very aggressive. You need to be aggressive to get back to where you were as far as that relapse goes. The last medication I want to talk about is Empira, which is a medication that helps speed conduction along the scarred areas. So this medicine can actually bring back strength to weak muscles and improve your walking. So you can see here the signal shorts out when it hits a scar. So only some of the juice gets to where you want it to go. With Empira, more effective signal goes to where you want it to go. So if you're bedeviled by walking problems, haven't tried this medication, this might be something to discuss with your healthcare provider. Other practical points: nicotine's associated with worse outcomes. Stop smoking. Exercise. The better shape you're in, the more energy you're going to have over the long haul. Very slow, gradual increase in exercise. UV exposure, 10 minutes prime time, helps your vitamin D better than any vitamin D tablet. Cooling vests are available to help you enjoy life in the heat, sometimes for limited times. Carbs take up a lot of energy. They cause a weight of gain, so as wonderful as they are, really, if you could reduce those, you'll probably be better off. We're educating the family today, and we need to empower you in doing the right thing. So these are our future challenges that I'll leave you with. We're not there yet. As long as we have relapses, there will be relapses today that will forever change people. They'll never walk the planet again. As long as that happens, we need more choices. That's why we need the FDA to overturn that decision on that once-a-year IV treatment. I'll be happy to answer more questions about that at the end. So MS is fatal. Set a very high bar of success for yourself. Follow up diligently. Treat relapses aggressively. This is advice to us. Manage symptoms as if we had them. And treat people individually. You know, the square peg does not fit in the round hole. So let's move forward. I want to thank Dr. Whitaker, who was my mentor and taught me so much about this condition. I owe him a ton. I also owe a ton to my staff, which came today to have a booth here on their off day and do more than you know behind the scenes for everybody. My parents, who inspired me. My children, who put up with Dad not being around as much as I should have been. And my wife, same thing, a saint who has raised our family without me present a good bit, trying to do what I can to better the world in this condition. And then God, of course, gives me all my ability. So sorry for the long-winded presentation. I appreciate your attention. And I'll answer questions after Dr. Kitchens.
Thank you, Dr. LaGanke. And next up, we're going to have Dr. Rupa Kitchens from the Urology Center of Alabama. And Dr. Kitchens is going to speak with you all about bladder issues. So let's welcome Dr. Kitchens.
Thank you. Hi, everybody. Everybody ate well? Okay, good. So now I got y'all, I know it's post-lunch, so I don't mind a few sleepy heads. If you need to excuse yourself, go to the restroom, please do. We're urologists. We don't want you to hold your bladder, so get up and move around as you need to. I'm one of 28 physicians in Urology Centers of Alabama. Our main office is in Homewood, not 10, 15 minutes from here. We go from Gardendale down to Prattville, and we go from Pell City all the way over to Bessemer and everywhere in between. So we have, Sherry, 15 locations now, so we are close to you guys wherever you may be. Today we're going to be talking about bladder issues. Some of the things we're going to be talking about is not specific to multiple sclerosis, and some of it is. And we have a fair amount of men and women here who I think are caregivers. And you can also have bladder issues with MS that are not related to MS. So some of this may be things that you've already heard about or you already know. I don't know how many of you already see a urologist. My opinion is that any patient with MS should see a urologist at least once or twice a year, because as what I always tell people who come in, MS changes from beginning as disease can progress or it can stay the same. And when the disease changes, your bladder changes, and it's important to keep up with that. And there's no way to know if it's changing or not if you're not seeing a urologist. So keep that in mind. Our objectives today is I want y'all to understand the syndrome of OAB. That is a short phrase for overactive bladder. We want you to understand how common this is in the community, in the country, the prevalence, the incidence. We want to identify types of urinary incontinence. Incontinence simply means leakage of urine. So you'll see incontinence back and forth in the talk. And most importantly, I want y'all to understand that if any of y'all have these problems, you're not stuck with them. We have ways to treat them and improve your quality of life. We may not cure them, but we can certainly try to improve and treat it. So there is hope for bladder problems, which is a big part, I think, of MS. So overactive bladder is a symptom complex. It's not a disease. You can have urgency. Urgency is that sudden need of having to go to the bathroom. So I see a lot of sweet tea on the tables today, and sweet tea is, or any kind of tea is a big no-no for trying to prevent urgency. But anyways, that sudden desire to have to kind of run to the bathroom. It can be accompanied with leakage. It may not be. And you might also have some frequency in the daytime. Frequency means voiding or urinating over 8 times during the day, and also getting up more than once at night. There's no other conditions that can explain these symptoms. There's no infection, no kidney stones, no other bladder pathology, and this can occur in 16% of the population, so it's very common. We see it all the time. The definition of incontinence, as I said, is the involuntary, unintentional loss of urine, having more than 2 leakage episodes per month. The older definition is where leakage is seen as a social problem, hygienic problem, and we can objectively demonstrate it. The prevalence is also impressive, anywhere from 25 to 45%. Daily incontinence happens a lot in our younger folks and a lot more in our older folks. 250,000 people in this country have a spinal cord injury, which we also see very often as urologists. Even more of that number have MS, so we are not any strangers to these neurologic problems. The incidence of incontinence, again, just a quick look at the numbers. It's difficult to tell because not everyone comes in who has leakage, and we'll talk about that as well. Incontinence can affect, again, about 20 million people in the country. About half of these are nursing home residents because it's, as the older you get, sometimes you're more immobile and it's harder to get treated. Again, a lot of women, a lot of younger women, a lot of healthcare costs, a lot of office visits. But despite all these prevalence and numbers and just how many people have this, we don't see a lot of people. I think we're seeing more because of the ads on TV, and yes, this is a problem and it's okay to go to the doctor, but a lot of people are still embarrassed to mention this to their physician. They might think that, oh, I'm getting older, no big deal, this is what's going to happen. My mother had this, I'm going to have it, I have it, so it's just part of getting older. And it is true, but you can still do something about it. Mobility issues, again, it just may be hard to bring my 90-year-old mother to the doctor because it's hard to get her transported to a doctor without calling an ambulance. And then, again, the positive family history. My mother had it, and so it's okay if I have it. So why should you seek help? Again, because it's so common. And because it's so common, the healthcare industry is focusing on this to try to bring treatments in, and we do have good treatments. We can actually improve someone's quality of life in a relatively easy manner in regards to sexual function, social activities, and getting some sleep. And leakage or having to run to the bathroom all the time does increase risk of falls, fractures, skin infection, pressure ulcers. These are their own problems in and of themselves. We don't want to encourage you to come into the hospital for those things. So there are certain types of urinary incontinence, and leakage is not just leakage. We have to figure out what kind of leakage it is, where the source is coming from, and then figure out what kind of treatment. And that's why you come to the doctor. That's our job. So we have to figure that out. We have 4 different kinds of leakage. Y'all probably didn't guess that, but there are. The first kind is stress. We'll go over each of these. Urge, mixed, which is a combination of stress and urge, and overflow. If we start with stress, and I'll say this, stress, this has nothing to do with MS, but I see a lot of women in the audience, and this is something that you all might experience with your mothers or with yourselves, regardless of a neurologic condition. This is just an aging thing, really. But this is to complain of leakage when you cough, laugh, sneeze, pick up something, jump on a trampoline, exercise, anything like that. It's the most common type of leakage we see, and again, we see it a lot in young women. Urge incontinence is, as the name suggests, urge. That is that sudden need to go to the bathroom. And you'll hear, you can't make it to the bathroom in time. There was an old commercial out for one of the medications for this to say, gotta go right now. This is urge incontinence. Can't make it. Leakage on the way to the bathroom. Mixed incontinence, again, is a combination of the stress and the urge. It could be, one could be worse than the other, or one could be less severe. And so we always try to attack both of them to try to treat. This is just a schematic saying that the mixed is a component of both, okay? And then the last one we'll talk about is overflow, and this is related to retention. Retention means the urine does not come out of the bladder like it should, it stays. And so you have more urine in your bladder than you should when you urinate. You should empty, but not all the time do we empty. And a lot of this we see in MS or other neurologic conditions such as spinal cord injury, diabetes. Diabetes is a neurologic condition. MS, stroke, Parkinson's disease. A neurogenic bladder is a bladder in a patient with a neurologic problem, and not all neurogenic bladders are bad, but when they cause urinary symptoms or leakage, that's a neurogenic bladder. So you might see that term. So risk factors. Of course, getting older. I'm not sure what good things happen when we get older, but this is another thing that can happen as we get older. Gaining weight, prior surgery such as hysterectomies, C-sections, vaginal delivery or trouble with labor, menopause, and neurologic issues, as you all know. As always, when you come to my office or you go to any urologist's office, we want to know what's going on. So we will ask you a lot of questions, and that is how we try to figure out what's going on. We want to know, how often are you going to the bathroom? Does it hurt when you urinate? Do you wake up at night to urinate? Do you have to run to the bathroom? That's urgency. What kind of leakage are you having? What kind of incontinence? Do you have a history of infections or kidney stones? Do you have to wear a pad if you leak urine? And if so, how many a day? Have you had any blood in the urine? What is the quality of life? If you wear 8 pads a day and you're perfectly fine, that's important. Some people might leak a trickle and it bothers them, so that also is important. Constipation, bladder, bowel go together. So bowel works good, bladder works good. Bladder works good, bowels work good. So that's important. And how much fluid? Are you drinking 2 pots of coffee a day? And is that why you're leaking? Okay? Or are you drinking everything normally, just like water only, and it's still happening? So we need to know those things. PMH means past medical history, past surgical history. We want to know what kind of surgery you've had, what kind of neurologic conditions you have. If you have a history of cancer, did you get radiated? Do you have diabetes? Do you have heart failure? All these things have urologic implications. We want to know what kind of medicines you take. Do you take a water pill or a diuretic? Have you taken medicine that controls your bladder? That's the general class of what we call anticholinergics. Have you taken antihistamines? Those are things like Benadryl, antidepressants, narcotics, or pain medicine. These are causes. If you look down this way, this is a mnemonic called diapers, which makes me kind of think about this. But these are all things that can cause leakage and then it goes away. But delirium, infection, if you have inflammation of the vaginal lining, that's called vaginitis. Pharmacologic or medicine, psychological reasons, you're making too much urine, you don't move around well, stool impaction, constipation. So once we ask all those crazy questions, we will examine you. And We'll always try to look at your abdomen and check your back. The most important thing is a pelvic exam because that's what determines what kind of vaginal support you have that supports the bladder and the urine channel or the urethra. Cystocele is where your bladder's falling. Women, you may be familiar with this. Rectocele is where your rectal is pooching up into the vaginal area. We want to look and see how stable your urethra is. We want to see if you leak, if you cough in the office. And we have to check something that's very important to us, especially if you're a neurologic patient, called a post-void residual. We want to make sure that after you urinate, which is the post-void, what your residual is, what is left over in your bladder. And the normal amount is less than 50 cc's. As you get older, I kind of fudge on that a little bit, but over 200 cc's is kind of a red flag. We don't want you to keep urine in your bladder because that may be a sign that your bladder muscle is not emptying well. It can set you up for kidney disease. It can set you up for recurrent infections. And no one wants a wimpy bladder. We want strong, efficient bladders. And the less residual you have, the stronger your bladder will be. We will also do things like check your urine, check culture for bacteria. The creatinine is a measure of your kidney function. And especially if you come in and I know you have MS, that's something I'm interested in because I want to make sure that your kidneys are at baseline stable, or if there's some damage, we need to know. Other studies we might do, something called urodynamics, which we'll talk about in a minute. This is a way to test and see how well your bladder functions, how well it empties urine. Cystoscopy is where we put a little telescope in your bladder, take a look at the inside lining to make sure there's no tumors or stones or any other foreign material that may be causing trouble, and a kidney ultrasound. What do we as doctors not want to miss? We want to make sure you don't have an infection. That's easily treatable. It's a pain, but antibiotics for a few days usually takes care of it. Bladder cancer is something that can cause trouble, but you want to know it if you have it. Kidney stones, bladder stones, constipation, again, as I mentioned, is something that most people don't think they are, but a lot of people, especially in Alabama, tend to be very constipated because of our diet and excess fluid intake. So again, going back to drinking and eating proper things. So if you're an MS patient and you come in and I've checked your bladder and you've just emptied your bladder and you have 300 cc's of volume in your bladder, that is worrisome to me. That's 10 ounces of urine that should not be in there. And so what we will do three things. We will, again, check your kidney function, make sure your creatinine level is normal. This is something that if you have a medical doctor, they will check it routinely with your electrolytes. So it gives us an idea how well your kidneys work. Kidney ultrasound, we want to make sure that urine in your bladder has not backed up towards your kidneys, causing your kidneys to swell or be dilated, because that can hurt your kidneys long term. And then urodynamics, as I mentioned before, this is a way to check bladder pressures. And your bladder does have a pressure. Normally we have a low pressure, high volume bladder, which is how you want it to be. But if the pressure in your bladder is sustained over 40 centimeters of water pressure, that can actually go transmit to your kidneys and cause kidney damage. So we want to make sure that that's not happening. Common urinary symptoms we see in MS. Bladder hypersensitivity. That means the nerves to the bladder are just, it's like someone turned the volume up. And they are just super sensitive, and it'll make you want to go to the bathroom even when you don't have to go to the bathroom. High pressure bladder, which can lead to insufficient storage of urine, insufficient urination, that means not emptying all the way, and because of that, leakage. Leakage of the bladder happens when the bladder is not happy, okay? And this is due to the demyelination, which is obviously present in the disease, and the disruption of the proper bladder function. So the bladder needs a normal brain for normal bladder efficiency. The goals. This is similar to what I think you were saying earlier about the home run. This is my home run. It's not a whole lot to ask, but we want low bladder pressures. We want the absence of infection, or at least as little as we can, and we want to keep your kidneys stable. If the bladder is dysfunctional, that doesn't bother me as much as we want to keep your kidneys stable. No one wants to be a dialysis patient if we don't have to be, okay? Okay, so y'all with me so far? Okay, good. All right, so now we're going to talk about the types of leakage and what we can do. This is obviously what we need to do is the important part. So stress incontinence, this is that leakage when we cough, laugh, sneeze, pick up things. Usually happens in women. This happens because there's that stress, is the stress of the abdominal pressure that gets transmitted to the pelvic area, and then the bladder can't overcome it, and out comes the urine. This can occur from sitting to standing. These patients may avoid exercise and or any kind of physical activity. Oh, I don't go to the gym anymore because I will leak. Oh, I don't do this anymore. I can't jump on the trampoline with my kids. So they just kind of back off and don't do anything anymore. The main etiology is we have a weak pelvic floor. The weakness can happen, again, with changes with aging, childbirth, weight gain, previous surgery. The pelvic floor muscles support the pelvic organs. And if you look at my picture, this is our pelvis. Man's pelvis looks pretty much the same way, but this is the pubic bone. And then you have this big wad of muscle that's like a big hammock. And it supports the uterus, the vagina, the rectum, the bladder, all that is in here. So when these muscles around these vital organs get weak with the aging and with the childbirth, pregnancy is a big thing, big babies, all that kind of stuff, then the muscle around the urine channel gets weak. And when the muscle around the urine channel gets weak, that's what causes the leakage. It's just not strong enough anymore. So like I said, instability of the urethra. How do we fix this? There's no medicine to fix this, not yet. So we want to try to restore the normal anatomy, try to get the muscles to be stronger. And again, like I said, very common in women. One thing we can do is, you all may be familiar with what we call Kegel exercises. That's a way to strengthen the muscles, try to contract the muscles on a daily basis. You can do this at home. You can do this while sitting here watching me talk. No one will ever know you're doing it. There's a way that it's very easy to do. Behavioral modification, we'll talk about that in a sec. What we call time voiding, avoiding bladder irritants. There's what we call bulking therapy to try to close up the urethra a little bit, and what we call slings to try to recreate the muscular support. So if we start with Kegel exercises, again, like I said, it's very easy to do. This is the same group of muscles that you move to try to start and stop your urination. You can practice in the bathroom, and then you can do it kind of wherever you are. If you don't do them, they don't work. So you have to be motivated, and you have to do them. Otherwise, they may not be successful. This is not a quick improvement, but it's a non-surgical thing, so that appeals to a lot of people. And biofeedback is a technique in the office that we can actually do to make sure you're moving the right muscles. So it's cheap, there's no side effects, and there's no surgery. So it's a great first treatment. There's always weight loss, smoking cessation, proper fluids, cough prevention. All of these things also help prevent leakage. We always ask patients to avoid what we call timed voiding. That means go to the bathroom by the clock, not by how you feel. So go in the morning when you wake up, look at the clock, go every 3 hours till you go to bed. So the idea is to empty out before you have a chance to leak. Double voiding means when you think you're done, wait about 10 or 15 seconds, push again, see if anything else comes out. You want to make sure you're super empty. And with the neurologic problem, I don't know how well your bladder works, so you really need to do as much as you can on your own. Avoid what we call bladder irritants, spicy food, alcohol, what we call the 5 C's, citrus, caffeine, carbonation, chocolate, cigarettes. And all these things can irritate the inside of the bladder. When the bladder is irritated, it leaks, or it makes you run to the bathroom, or it makes you go more often than you need to. Urethral bulking agents are a type of material we can inject directly into your urine channel. It can be done in the office, it can be done in the operating room. It is a temporary thing, it requires repeat injections. This is good for someone who doesn't want a big deal, who doesn't want to be put to sleep. Older people, it's good. Even though it's repetitive, we have to do it again. So the way that works is, this is your bladder on the left. The little telescope goes in. We have in the second picture, there's a little needle that goes in through the scope, and we actually inject some material. And if you look over here, you can see that the urethra kind of closes up. It doesn't cause you to not be able to urinate, it just gives it a little more bulk so that the leakage doesn't happen. So on the picture on the left, you see a wide open urine channel. The bladder is back behind here, okay? That's the urethra. And then when you put this muscle in, or this material in, it closes up, or it coapts together. And that's it's almost like you're closing the gate and that urine can't leak out. Easy to do and pretty successful. Slings are materials that have been around forever. We've been doing these for about 30, 40 years, and they are made of various materials. They can be made of polypropylene mesh, dermis, which is the material underneath your skin, other biologic materials, and they're placed under the urethra via a vaginal incision to create that same kind of muscular support that we were looking for that has gotten weak. 85% effective on average, they can range from 70 to 90. Immediate results, so if you cough in the hospital on your way out the door, you shouldn't have any leakage. It's very effective, and it can be done as an outpatient. So that's stress incontinence. That's that leakage where we cough, laugh, sneeze. The other kind of leakage that neurologic patients may be more familiar with is something called urge incontinence. Again, that's that have to get to the bathroom right away, and it leaks on the way to the bathroom. So again, you can have frequency with that, where you're running to the bathroom often. You could have the urge, or you could have all three. The reason for this is the nerve terminals in the bladder are overly sensitive, hyperactive. There's a leak of a chemical that activates the nerves and causes that bladder contraction, and then the urine comes shooting out. So the reason this can happen is pelvic surgery, getting older, getting more weight on, again, impaired mobility, same kinds of things for the stress incontinence. These kind of patients have a fear of leakage. They just don't want to leave the house. They don't know when it's going to come. It could happen anytime. They can give up hobbies, travel, shopping. They know where every bathroom is from their house to Walmart, 15 minutes down the road, and they know where to go. Bathroom mapping. So it's a sad situation. It can lead to social isolation. A lot of caregivers, children can't put up with this or can't take care of their parents at home, and so a lot of people get admitted to nursing homes or assisted living because of these types of problems. So again, there's treatments again. You'll see that the Kegel exercises are the same, the behavioral modification is the same, the time to double avoiding irritants, but in this category, for urge, we actually use medication, whereas with stress, we do not. Remember, it was a muscular problem, so there's not really anything to target with that. But here, this is a bladder problem. So we have two classes of drugs down here at the bottom, which we'll go through. And I'm going to breeze through the, and then these are, I would say the first four are first-line treatments. If those don't work, we go to medication, which a lot of times we'll do on the first visit. Second-line treatment is procedures that we can do, and I'll go over all these. Sacral neuromodulation, tibial nerve stimulation. The tibial nerve is a little skinny nerve that you find in your leg on the lateral aspect. And then the botulinum toxin, which is otherwise called Botox, that's a relatively new thing that we can put in the bladder. Last resort, or third line, is what we call bladder augmentation. That's where we make the bladder bigger. It's a fairly decent operation to go through, so we'll talk about all that. We've already talked about Kegel exercises, so I'll run through all this. We've already seen all that. The first-line therapy that we use for urgency or urgent incontinence is in this class called anticholinergics. That's the name of the class of drugs. This is what we've used for about 20, 30 years. And it acts on these receptors called M2, M3. The type of receptor is called muscarinic. That's a little spot in the bladder where these medicines attach to, and they stop these involuntary contractions that the bladder has. So it makes the bladder calm down, less hyperactive. These are various medicines that we've had. There's different variations of these too. Some are topical, some have patches, some are pills. But regardless, even though they have about a 70-75% success rate because of cost or side effects or whatever, there is a fairly high discontinuation rate in the first year. Just in the last year or two, a new class of drugs has come out called beta-3 agonists, which have a more favorable side effect profile than the other kind of drugs we had. We have one medication in this class called mirabegron. Instead of, it kind of does the same thing, but it works in a different way. It works at a different place in the bladder to actually stimulate it to relax. And you don't have the dry mouth, the constipation, the dry eyes, the blurry vision that you have with the other class of drugs. So it has shown some promise. So say you've taken all these medicines, you've done your exercises, you're not drinking your 4 pots of coffee anymore, and you're still having persistent symptoms despite oral therapy. Then we move on to plan B. we as surgeons always like to go from easy to hard, least invasive to more invasive, because if something works that's easy, it's better for the patient. So we have 4 options that we'll go over, and the first one is sacral neuromodulation, and we'll go through each of these, the tibial nerve, again, the Botox, and the bladder augmentation. The sacral neuromodulation is a way for the bladder nerves to be regulated better. And the way we do that is we put a little neuromodulator, it's like a little battery, implanted into the lower back, and the sacral nerves, which are in your tailbone, one of those called S3 goes to the bladder, and it changes the activity, tells the bladder to calm down. It's an outpatient procedure, 70 to 80% success rate. There are 2 stages, stage 1, stage 2. And the nice part about this procedure is if stage 1 doesn't work, we don't move on to stage 2. So we don't have to implant the whole thing to know if it'll work or not. If stage 1 doesn't work, then we know to quit. The way it works is, here's your lower back, and the tailbone is here. We find that area where that nerve is called S3, and we put a little needle in there. This is done while you're sedated. You don't have to be asleep, but you're not completely awake, so you're comfortable. And then we put a little electrical lead into that area using x-rays. And so here's that electrical lead going into where it needs to go to stimulate the bladder nerve. And then if it works well, patients go home. 5 days later, they come back and they're dry. They can hold it and make it to the bathroom in time, and they are happy with it. Then and only then will we go back to the operating room and attach this little battery to that lead, and then it'll be internalized, okay? So it's almost like you have a pacemaker for your bladder, okay? It can be removed, it can be turned off. So you're not stuck if something happens later on. But we have very good success rate. Patients are very happy with this because it really does change the quality of your life. Percutaneous tibial nerve stimulation is very similar, except we are stimulating another nerve called the tibial nerve. And this is stimulation in the lower part of your leg near your ankle with a small needle, and those impulses travel to the sacral nerve, which we just talked about. It's very non-invasive. It's a very small needle. You can't even feel it when it goes in. And there's 12 treatments, 1 back-to-back, week after week, 30 minutes each time. Botulinum toxin, or Botox, as most of you may understand it as, is for, it was designed for what we call neurogenic bladder overactivity. So again, remember, neurogenic means having a neurologic problem. Bladder activity is that hyperactivity of the bladder. What we do is we put 20 to 30 small injections of Botox in the bladder wall with a little telescope. Again, we can do this in the office, wide awake. You can even watch it being done by your urologist. And it takes about 10 minutes, 10-15 minutes in the office, or it can be done in the operating room. What this does is it causes those neurotransmitter levels to decrease, those chemicals that are making the bladder muscle push urine out, push urine out. And then what happens because of that is the bladder muscle weakens or becomes paralyzed. And again, it can be done your preference. The results of this are less incontinent episodes, less urge, less frequency. The average was down to 1 to 1.5 episodes a day after 6 weeks. Usually see a result from anywhere from 2 to 6 weeks, and it increases your bladder capacity, which is a good thing. You want volume. You want to decrease pressure. Remember, I said high pressure is not good, and we can see an improvement anywhere from 2 weeks to about 6 weeks, and then it lasts for about 6 to 10 months. It's not a one-time fix. Yes, ma'am.
With this and the last one,
Uh-huh.
would that allow a person who has a catheter for them to come off of the catheter?
It depends on what okay, so the question is if someone has a catheter in, would these 2 things help coming off the catheter? It depends on what the catheter was put in for. So just not being able to empty. So this would not help with that, not Botox. But the other one where we put the little device in, we can sometimes use that for urinary retention. I had an 88-year-old guy who had a catheter in forever, and we did we did the electrical lead thing on him. He's voiding fine now. It's not what it was necessarily indicated for, but it has helped people in urinary retention who have to have a catheter. Good question. So with Botox, relatively benign procedure. There's a 18% of infection. We always want to make sure your urine is clear before the procedure, and make sure you don't have an infection before we put the scope in. There is a small chance, remember, we're relaxing the bladder. We're paralyzing the bladder muscle temporarily. So there is a chance that you may not be able to empty your bladder fully, but that's only 6% of the time. But you have to be prepared to pass a tube in your bladder in and out if that does happen. But it is a small percent. Small chance of having to catheterize, and again, retreatment every 6 to 10 months. And again, if it's done in the office, it's not a horribly invasive procedure. Bladder augmentation is not something that we see a whole lot of anymore because we have all these intermediate things that we can now do before. But this basically involves an abdominal operation. You find your bladder, we open the bladder, then we take the small intestine, we open up the small intestine and attach it to the bladder and basically make a bigger bladder. So you still have your bladder, but we're trying to make it bigger, which is the augmentation part of it. The idea behind that is, again, to hold more volume, less pressure, less leakage. It is a last resort. There's a slew of surgical complications that can happen from it because it's it's a big deal. I can't remember having done one in the last several years. It's been a while. So we're not having to get to this anymore. There are some new things being done. Of course, there's a lot of research, I think, being done in MS anyway, but as far as the bladder goes, I recently read of one study going on now where they're actually trying to find this little channel in the bladder that may have a role just for bladder dysfunction. And this thing is called Panexin-1 or PANX-1. And I only bring this up without going into a lot of detail because I want y'all to know that there are people out there, urologists, who are looking at regulatory systems in the bladder itself that can be manipulated. Of course, these have a little ways to go, but there is always that trend of wanting to do more, wanting to do better, and always trying to improve what we can do. Okay, so that whole section was on urge incontinence. Medications and surgery can be used to treat it. Our third one, remember, is mixed. And again, you'll see elements of both stress and urge. We try to treat both. It's not we pick one. We try to address everything. The overflow is important because we see this in people with neurogenic bladders, probably like the patient you mentioned. Diabetes, spinal cord injury, MS, anything like this is a red flag to us that yes, we need to make sure they're emptying their bladder okay, and that obviously for obvious reasons. So we see this in detrusor atony. Atony means weakness of the muscle, so weak bladder. You don't have to have a neurologic problem to have this. You could have a long history of infrequent voiders. Nurses and teachers are especially dinged for this because they just can't, they're so busy they can't run to the bathroom. So you have people who urinate once or twice a day and then all of a sudden they're 70 and they've been doing this for years and their bladder is not efficient anymore. The bladder muscle has become weak and they just don't empty well anymore. So it's not a good thing to do to hold your bladder. Long history of chronic bladder outlet obstruction. Bladder outlet obstruction is only caused by mainly one thing in men, which is enlarging of the prostate gland, which is a whole nother topic. B12 deficiency, alcoholism, so you don't have to have a neurologic problem to see this. How do we diagnose this? Again, we want to see how well you're emptying your bladder in the office. Treatments, chronic Foley catheter, which is never fun for anybody. A suprapubic tube is a tube that is put into the bladder through your abdomen. Both of these, the tubes have to be changed out monthly. Intermittent straight catheterization, where you pass a tube in your bladder 2 to 4 times a day, depending on what your volumes are in and out. There is a pill to help you empty your bladder called bethanechol or urocholine. It is not a great drug, but it is the only drug we have to kind of help push the bladder, the urine out by working on the muscle. And there's other things that what we call alpha blockers, such as tamsulosin. Y'all may have heard of something called Flomax, that kind of thing, which we give for enlarged prostate. So there are ways to help overflow incontinence, but you have to figure out why it's happening in the first place. And again, with this, because of a full bladder, we have to watch your kidney function or your renal function. The creatinine, again, is something we check, the ultrasound of the kidneys, and again, the urodynamic studies, which are something that we do in our office. It's about a 45-minute test to, again, check to see if you have good bladder function and make sure your pressures are not too high. I think that's all I've got. Okay, does Stuart, I think I'll turn it back over to you and we can do
Well,
questions.
that would be a great idea. But thank you. So thank you for coming.
Thank you for your attention.
So now we're going to head into the Q&A. And what we're going to do is Ken over there with the white shirt with the MS Views sign on it, he's going to run around on that side of the room. We're going to go back and forth and take questions for you. Remember that we are not going to put the cameras on you. We just want to hear you. And also, if you're shy and you don't want to stand up and ask a question, then just hand it to either myself or to Ken, and we'll ask the question for you after we step away and nobody knows where we got it from. Okay? I'm going to give you one to share. Okay. All right?
Check it.
There you go.
Dr. G, thank you. I have had MS now for 34 years. I was very excited about this seminar today because I've heard you say something that I have never heard a medical professional admit, that MS is terminal. For years, everyone says, oh, it's not terminal, it's not terminal. And you're the first one I've ever heard admit that, and I know that to be factually true. What has changed the general attitude now, and are all neurologists finally getting that mindset to understand the truth?
I think it's we're moving in that direction. I think the study, that the long-term study with the original medication, beta interferon 1b, beta seron, looked at survival, which then made people look back at insurance claims, life expectancy, registries, and compare age of death, reason for death, and really made us examine that and come to that conclusion. So I think it was really through those means that we now appreciate that. Yep.
It's made it easier on us, people that are in the support field, because they were always looking at us like we were liars.
Right. Well, that was one of the myths. Yep.
The reality is we knew all along it was. We just wait for y'all to catch up.
We finally got there.
Everybody, please remember that we want to have the microphone on you when you're speaking. So if you need to say something else, just turn around and find the person that just had the mic and get him back over to you. So next is over here.
Dr. Kitchens,
Yes, ma'am.
can we talk about kidney stones?
Sure.
When one sibling has kidney stones to the extent that it kills her, what is the consideration for the other sibling?
For the other
Sibling.
siblings, was it a problem with infection? Was that the thing that caused the death?
It went septic overnight.
It went to what?
Septic.
Septic, okay.
My sister died from kidney stones. She saw the doctor. He said she needed surgery the next day. Instead of putting her in the hospital, she was found dead.
Yeah, that's really sad. I'm sorry. Our approach to kidney stones is two things. You don't wait on them, okay? I mean, there are some you can, but in general, you can't just say you have a kidney stone that's obstructing the kidney and say, pass it, call me if you need me kind of thing. You need to make sure it's gone. Second thing is prevention, okay? Kidney stones can run in the family, not always. So if there is a family history of kidney stones, they should be checked out just to make sure. That can be done with simple x-ray. But we will usually, we find with your situation, someone comes into the hospital, they're running a fever, you have to get that kidney drained as quickly as possible with surgery. Not necessarily removing the stone, but putting what we call a stent in or a tube in the kidney to drain the kidney, get the infection out. And if that's not done in a timely fashion, it can be disastrous.
I've never had any.
Okay.
So that's a good thing. And like I said, prevention, I'll just say this very quickly because it just takes a couple of seconds, but high fluid intake, lemonade, orange juice, whole wheat, high fiber are things that are the good things. And the things to stay away from are things a lot of salt, a lot of meat, spinach, tea, chocolate, nuts, colas, grapefruit juice. All the things that people seem to like. So the big thing is identifying what you could be doing wrong and then trying to mitigate those as much as possible.
I'm drinking water, but I eat spinach.
Okay. Well, just cut it down a little bit. You'll be all right.
Okay, remember everybody, raise your hand so we know where to pick on you.
Dr. LaGanke, I'm sorry, I could have asked you in the office in the past few years, and I haven't.
That's fine.
What is there a connection with your feet, at the bottom of your feet hurting? Just hurting when you go to bed, and even especially up on the ball of your foot, around your toes, it's just miserable.
Yeah, so the question is there a link with MS and pain in the bottom of the feet, especially at night, an aching type of pain, but there are a whole variety of different kinds of pains. Yes, it can happen with MS. You can have, most commonly then, a spinal cord lesion that would govern the signal down to both feet. Usually brain is one side or the other, and spinal cord is usually symmetric in the extremities. But just confined to the feet, and if you'd never had a relapse before that affected your lower extremities, more likely it's peripheral neuropathy, which is a very common condition, and just because you have MS, you're not immune to getting other things. So peripheral neuropathy, really common, numbness, tingling, burning in the feet, may stay there, may work its way up the limbs, and there are many causes of peripheral neuropathy that are unrelated to MS, and there are a lot of first, we try to find the cause, intervene there, because there are some things that we can do to stop progression, and then there are a lot of symptomatic medications to help ease the discomfort with it. Yeah.
Okay.
Dr. Kitchens, would you explain how you said the antidepressants and the antihistamines affect bladder function?
They both slow down the bladder. So your bladder can become kind of lazy, and then you run into that thing where you're not emptying well. And we see that a lot, people with multiple psychiatric medicines, and it's not my place to reduce those doses, or because I don't know what you're on them for and that kind of thing, so I will call the psychiatrist and say, hey, we're having trouble emptying the bladder. Is there anything that we can do to change medicines, change doses, so we can change the side effect profile to be a little more favorable?
Yes, Dr. LaGanke. I was wondering with the relapses, does that have to be 24 hours continuously, or can it be intermittently, or, and also when you have a relapse or having problems, can you have different symptoms and not have a change in your MRI ever?
Okay, so first question, by definition, relapse, 24 hours continuous symptoms. But there are exceptions to any particular thing. So if it's something you've never had before, it's occurring for most of the day and maybe recurs for several days in a row, and maybe you get a break, or it's less to an extent that you don't think it's there, then it's possible. But those are the definitions we use for clinical trials and in clinic, and just kind of a down and dirty for you to kind of understand, is this a relapse or is this just an aggravated symptom? If you've never experienced it before, or if you have any doubts, you call your healthcare provider and just say, I've never had this before, it didn't last 24 hours, I'm not sure it's a relapse, but what do you think? It could be something, again, completely unrelated to MS as well. You're not immune to that. And the second question was regarding...
If you have different symptoms, can your MRI stay unchanged with having different symptoms?
Second question, new symptoms haven't experienced before. Can the MRI be normal? Our MRIs are getting better and better and better at detecting lesions. So it's pretty uncommon to have a new relapse and not have an area on the scan. That's uncommon. I didn't say impossible. And then you have to make sure you're imaging the right place. So if one has, let's say, both hands getting numb, working its way up the wrist, and someone takes a picture of the brain, nothing new, well, it's probably because the problem's in the spinal cord. So you have to make sure you image the appropriate places that might account for the problem as well before you conclude that we don't see any lesions that are accountable for that problem. So yes, you can have symptoms without a finding on the scan. Make sure, though, that you image the appropriate places before you conclude that there are no new visible lesions. Lesions can be small. They may be out of the window of what you look at with your particular MRI protocol. Some of them have wider gaps in between. You want to make sure it's an appropriate strength MRI as well, because as I said earlier, if you had an open MRI, you might miss some things that are clearly there on a stronger magnet.
Over on this side of the room. By the way, we're getting a pattern here. That side of the room is for Dr. LaGanke. This side is for Dr. Kitchens.
We'll switch.
Okay, Dr. Kitchens.
I'll just walk over here.
Okay. I was curious about the directions on Flomax from my physician, my urologist, that is.
Mm-hmm.
I was told to take the Flomax 30 minutes after I eat my evening meal. What is the particular objective of that?
You mean by taking it after a meal?
By taking it 30 minutes after the meal.
The way they did the data in the studies, the medication was more efficacious with a full stomach.
And how long?
And it can be 30 minutes after any meal, as long as it's the same meal.
Okay.
I tell people after dinner also, only because you're not necessarily out and about after dinner, and there is that 17% chance of dizziness.
Okay.
So, I think it's just safer to be at home and maybe about to go to bed.
One quickie. How long post taking the Flomax, if you wanted to take a snack or something, to get the full benefit from the medication?
You mean after dinner?
After dinner, yes, correct.
Oh, I think, as long as you have food in your stomach, that's the main thing.
Okay.
Okay, it just did not work as well on an empty stomach or before a meal.
Okay, thank you very much.
Yeah, you're welcome.
Dr. LaGanke, the new intervention that was turned down by the federal government, I'm curious as to whether there are other steps for approval, or was that the final turn down? Okay. If it was the final turn down, where did we go?
Very good. Question was, with the most recent medication that was disapproved by the FDA, Lemtrada, is at the end, is there an appeal, what's the situation? So the up-to-date situation is we've advocated patients, if they felt the desire to do so, to write their congressman. Stu did an outstanding job putting a petition online, over 5,000 signatures protesting that decision. Very, very helpful in this movement. And there have been a lot of patient petitions. There's been a lot of movement that disagrees with this decision. We're the only country of 34 not to approve it, and we had the most subjects in the trials in this country. So it's just not tenable that we have maybe the most effective medication for MS, and we don't have it available in this country. So I think continued pressure, emphasis. I did an ABC spot here in Birmingham, wrote an article in the Birmingham paper, in the Chattanooga paper, USA Today. A lot of us in different areas are trying to touch our local media outlets and to try to put pressure. And all of that has been successful. All right, so your voice, all of you have spoken up, and through the petition that Stu and others put forward, the FDA this week, on Monday, said you don't have to appeal the decision, resubmit for approval. So, to me that would say they're very likely to approve the medication. So there's no timeline, don't know when that is at this point, but it looks like there's been a turnabout, and I think it comes from pressure and organizations that have put pressure on the FDA.
Who didn't understand that a double-blind study couldn't be done in such a case.
Yeah, there's a lot of conjecture, and my personal view is they had asked the company to do a trial a certain way, and the company asked them and the European equivalent how to do the study, and there were different opinions, and then the steering committee that oversaw the trial said that the European way was a more practical way. And I think there were some hurt feelings over that the FDA's version was not chosen. That's just conjecture on my part. I think now they see that we really can't keep that decision standing. So I'm very pleased. FDA, don't want to malign them. In the MS space, we've had more medications than any other country up to this point. I launched one of the medicines in Japan, and I launched one in Australia. And at that time, those countries had half as many medicines as we did here. So don't want to just blanket charge them, but to my opinion, they dropped the ball on this one. We really need to have them do the right thing, and it looks like it's turning. So that's good.
Next question's on this side of the room, and it's breaking the mold.
Uh-oh. Would be you.
Thank you. Other than MS, what else might cause the white matter lesions?
Okay, remember you have to memorize that list and you have to write it down before you leave the room. Well, that list was a list of other things that can cause white matter lesions. The more common things that we see in someone 20 to 50, the typical age of MS is lupus, sarcoidosis, Sjogren's disease, B12 deficiency, premature hardening of the arteries, Lyme's disease in certain areas. There are a number of different things that we typically, our usual profile that we look at. We don't exhaust that list usually, but there are a number of things that can mimic to a T. White matter lesions look exactly the same, symptoms exactly the same. So we have to exclude these other conditions before we 100% say that it's MS.
Okay, I've got one for both of you. What about urinary tract infections repeated over and over and over and over and over again? And Dr. LaGanke, you mentioned anti-lingo riparicinylin. Is that a treatment like Copaxone Rebif, or is it an addition, something you can take? And can you give more information on that particular one?
If we can document that there are repeated urinary tract infections, which means we see positive cultures, and there's not just symptoms, but bacteria that have been documented. Two things happen first. We do an x-ray of your upper urinary tract, kidneys, all the way down to the bladder to make sure, to really exclude stone disease, because that can cause an infection to form. The other second part of that is we have to look in your bladder, so with a little scope that we can do in the office. So we actually basically have to look at the whole urinary tract to make sure there's no obvious lesions that are causing the infections to form. If none are found, or if we find something, we take care of it. If none are found, then there's one or two things that we can do depending on the patient. We can put you on what we call suppression therapy or maintenance therapy, where we give you a low-dose antibiotic every day to prevent the infections from happening. It doesn't take it away completely, but the frequency really should go down to where it's not bothersome. It's a quarter of the treatment dose, so we don't expect resistance or to get immunized to it. And then there's also a hormone cream that we can apply vaginally, which also helps keep the bacteria away. So those are preventative things.
With regard to anti-lingo, it's a monoclonal antibody that is designed to remove lingo. So it's called anti-lingo, to remove lingo, which is a chemical that we believe impedes remyelination. So good Lord gave us the ability to heal. If we have a cut on the hand, we heal. Same thing in the brain. The brain sends out the machinery to heal, but there are some blocking substances that don't allow us to remyelinate. And this is one effort to try to remove one of those impediments to remyelination. And so it's given as an IV right now in the trial. This is first phase in human. The first phase study was found to be very safe. The second phase is the first study to really look at effectiveness. So it was chosen to do 18 months, once a month, as far as an IV treatment. That may be too much, maybe too little, maybe just right. We don't have any idea. That's what we're trying to figure out. It's given in addition to a disease-modifying medication. So that anti-lingo is not going to protect an individual from having new lesions. That's not the design of that. So we need to be on something to keep the disease at bay while we're trying to fix it. So hopefully it's going to be an effective agent, but we'll let you know in a year.
Next question's on this side. Hold the mic closer.
Okay. I'm going to be moving out of the country, and I'm on Tysabri. Now, what can I do to go from Tysabri to another drug?
Okay, so moving internationally, some countries have that medication available, and the first thing to do is look globally to see if you would have access to that medication, if it's the medication that's worked well for you, and that's the medication that is deemed to be best for you at that time. It may take some effort to figure that out, but let's take your scenario and say that it's not available. Then how do we come off Tisabri? Well, we do it in different ways. If you're JC virus positive, we do it in one manner. JC negative, do it in another manner. I'm not going to go into your particular instance, but we have different strategies depending on whether you're positive or negative. Just as a general, if someone's coming off Tisabri, been on it a while, and are JC virus positive, there's a particular time frame that's really, really important to get on something else, or one can have significant rebound disease. And if you add something a little too soon, it may increase your risk of developing the brain infection. So that's really a very fine line as far as timing of going on an agent when coming off Tisabri that way. If you're JC negative, then there's not that issue, and we'll implement a treatment right away, pretty much right away. So I can talk to you about a particular later, but not in this venue. But that's kind of the general principle of how we would do it.
Behind the light.
I have another question. You brought up vertigo. I had an experience with vertigo. The thing is, I have MS, but I don't have problems with heat. I was at the beach having a great time, and I was in a really hot place. But every time I touched the water, my head started spinning. I just get out of the water, and things are fine. And I really couldn't quite understand that. Now, granted, I did have something to drink, but I don't think I'm a big guy, and I drank hours before the beach, and I had a meal between. I don't think that was the case.
You didn't only drink in the water, did you?
No,
yeah.
I was trying to be, but yeah, I don't. Is there any particular reason why that would happen? That I just feel that way as soon as I get in the water.
Anybody in the room with MS have weird symptoms? The majority have raised their hand. So this is a disease that is prone to have very odd and unique symptoms, and I would just off the cuff say that probably getting into the water stimulates a certain pathway, a temperature change that would run its way up the cord. It would hit an area of scar in the brainstem, cause it to short circuit, come back and make you feel that way. When you remove that stimulation, then you don't have that stimulation to that area. That's how I would explain it. Whether it's true or not, I'm not sure, but really weird, strange symptoms that are triggered by things is very, very common, and we kind of lump it into short-circuiting events or aphaptic events that occur.
Right here, please. Toward the light.
I got questions for both of you. Bladder spasms, can that be considered a flare-up?
I would say only if they don't happen very often. But usually if you have bladder spasms or overactive bladder, it doesn't come and go in a short period of time.
Well, I mean, I was having them after a surgery, and they were just so bad that the urologist had no explanation other than it had to have been my MS after some point. Next question.
I'll finish that. So the question then, if I can put my 2 cents worth in. After surgery or major stress to the body, you can stimulate a lot of neural circuits, and we'll see a whole lot of symptoms emerge post-surgery. And a lot of times it's spasticity of muscles that are out in the periphery, not the smooth muscle of the bladder necessarily. But I'm sure that stress on the body triggered the bladder to go into those spasms. And it's not that it was a relapse per se, that you had a new area of damage in your spinal cord that would have caused that, but it just enlisted it or short-circuited in one of the old scars that you had and just made you have a lot of spasms.
It was several weeks after the surgery that it started, and so they had me do the steroids, and it seemed to have calmed it down enough.
Yeah, steroids are very good anti-inflammatories, whether there's active MS lesions or just inflammation in general. It's very good to calm things down. So steroids is kind of a shotgun treatment, which can help whether you are having active MS disease or it's just acute low back pain from inflammation or inflammation across the board. Steroids are an anti-inflammatory and may assist in that anyway.
Yeah, I mean, it calmed it down for the infection spasms to start up on their own. Okay, my next question is chronic infections common with having the catheter, and what can be done about that?
You mean indwelling catheter?
Yes.
Suppression therapy, really? Or trying to go to another mode of therapy?
Well,
I mean, infections are common with having a catheter in.
And I understand that, and so I did go to the suprapubic catheter, thinking that would be the answer. It has not.
Suprapubic catheters, I would say, probably have the same amount of infection risk because it's still a foreign object in your bladder.
So I'm finding that out, and I don't get these little infections. I get these big.
I mean, for drainage-wise, suprapubic catheter is preferred by urologists in general because you're away from the urethra. Okay, so if you don't have this tube sitting in this 3-centimeter channel, day in, day out, you don't have pressure on that wall, and that wall will erode after a while to where you don't have a urine channel anymore. And then you have this constant leakage because the catheter is not holding the urine in, but you don't have that with the suprapubic catheter. So we always try to encourage, if we know it's an indwelling catheter that has to be in for long term and we know there's no other options, suprapubic catheter is always a better option.
Okay, we only have time for 2 more questions on each side of the room. So that's all we have time for is 2 more, and we're going to do the first one over here. Did you have one?
I do, but she answered it. Okay, my question is kind of similar to the lady that was speaking about having surgery with new symptoms. I recently went through an episode where my stress level increased quite a bit. This is for Dr. LaGanke. And I had 3 new symptoms, one which only lasted for a couple of days, one which lasted for about 2 weeks, and one which was intermittently over 2 weeks. Once my stress level decreased back to its normal and just had the normal flare-up of my old symptoms, is that something that I should consider that I could have possibly had a relapse?
Yeah, so it's difficult. Most of the time, stress brings out old symptoms, not new damage. But there are occasions where, along with the stress comes a relapse. So it's not set in stone. It's not perfect either way. If they went away with the stress, then they may have been old lesions, some of which never had caused you symptoms before. Because remember, you get 9 new lesions for everyone that does cause you a symptom. But those 9 that you accumulated under the wrong circumstance may not function very well and may not transmit very well. So it still could be, even though you never had that symptom before, that it was due to an old scar. It's possible, but it sometimes requires us to dig further, take some pictures, look, see what we can see, and even if it's a new lesion that is so small it doesn't have inflammation, you don't need to subject yourself to going through steroid therapy for that particular one, and fortunately it went away within short order. So from here forward, if you have undue stress, those symptoms may come out again, and that would be not worth you going on steroids. So yeah, it's sometimes difficult.
Let me ask a question. Okay, my question is for you, Dr. LaGanke. When changing medications, is it important to have an MRI prior to and then after you've been on the medication for a certain length of time to get the best indicator of how effective it is? I know some insurance companies only pay for MRIs at certain points, so how do you use MRIs in determining that?
Okay, thank you for the question. So it's the question's about with changing therapy, what do we do with MRI scans, basically? And ideally, if you haven't had an MRI in a little while and we're changing therapy, we would like to have one around that time to serve as a baseline. Because again, those silent lesions predict worse disability, and how would we know where you are when you started this therapy if we didn't have an MRI scan around that time? It doesn't have to be the day you switch, but around that time, it would be nice to have a picture. And then yes, we monitor progress at set intervals, and it depends on the person's history, how frequent they had relapses in the past or active lesions, how long a person has gone without new symptoms. So typically yearly for the first 5 years, and if everyone's stable, if a person's stable on that treatment, then it's going to be every 1.5 to 2 years, and we lengthen it out accordingly. But there's no perfect set plan. It's very individualized, and part of that is how your particular disease has coursed along the way. Because if you have very active disease, and maybe we're going to look at 6 months instead of waiting a year to get that next scan, even if you're feeling well, if you've had a lot of disease activity in the past. So it's individualized, but we philosophically would like to have one around the time of a switch, and then we would at some point later like to make sure that that therapy is keeping new lesions from occurring as well.
This side.
My question is for Dr. LaGanke. I too, for the first time, have heard that this disease, MS, is fatal. When I was diagnosed, I was told that it was treatable but not curable at that time. And so I'm wondering, could you elaborate a little for me on that? Because if a person has been on several different therapies over a course of their lifetime and, you know, slowly progress and they pass away, is that considered dying from MS or what?
Okay, so a couple parts to your question. One is this disease is fatal. I think those of us in the field would acknowledge that untreated MS is fatal. Untreated is the key part of that. And we have seen marked differences when we have treatment, people on treatment. We don't see secondary progression, we don't see more disability, we don't see an increased propensity for infections that may then be very harmful for someone who is very debilitated. So we see less, or we see prolongation of life and function on our treatments. It's not quantified. We do not have any quantification to say this treatment, that treatment in particular will do this for you, or if you've tried 5 and you've been treated for X amount of years, does that, and then you stop, does that increase your risk? We just don't have that information to be able to provide it for you to say what your outcome will be. We do think that treatment will have a positive effect on longevity. Even if you have some disease while on that particular treatment, likely it would have been worse without, and that was a situation before we had any of these treatments, and we saw from our natural history that it was fatal. So we would encourage strongly to be on something, if at all possible, to attenuate the disease progression, believing that it's going to affect your long-term outcomes. As far as death due to MS, there's a lot of debate about that. Is an infection death due to MS? Well, if it occurred because someone was so debilitated that they wouldn't have been if it wasn't for the MS, then sometimes that's counted as death due to MS. That's not clear-cut either, but I think there's a little bit more latitude in explaining that if MS was not present, this would not have happened, therefore it's death due to MS. Even if it was, let's say, a blood clot, someone wasn't moving their legs very well, and then that blood clot went to the lungs and killed the person, we would say that's death due to MS, secondary to a pulmonary embolus from the DVT that was caused by the MS. So still working that out to get good numbers, and it would be helpful to be able to give numbers to have appropriate funding for this or that, or to encourage a person to be on therapy if they don't feel like it's ideal for them. So long-winded answer, but we're still trying to work that out. We all believe that it is a fatal condition untreated.
And the final question.
Yes, Dr. LaGanke, what would be the transitional period from going to the 3-time-a-week Copaxone to the weekly? Are there going to be skipped doses somewhere in there, or how is that going to work?
So the Copaxone treatment, it's a daily treatment now, and we're going from daily to 3 times a week. And that transition is you stop the daily treatment for 48 hours and then start the 3 times a week dosing. That's what's the suggested transfer is. There's no titration. It's just stop the 20 dose, and then 48 hours later start the 40 milligram dose.
Okay, so I'm sorry, we have to cut it off. Well, otherwise we could be here all day answering questions. But if any of you have questions still for either of these doctors, please send me an email. I'll forward it to them, and hopefully they will answer you directly, or they'll have to send it back through me. But I do have one final question for the day. Did you all enjoy today's program? Which leads me to another question. Do you want us to come back and do another? And here's the answer. So I want to thank Doctors LaGanke and Kitchens for being here today and helping to educate you all. And again, we want to thank Teva Neuroscience and Genzyme, a Sanofi company, for enabling us to do this program. Thank you.